Good morning, everyone. So I'd like to welcome you to the O'Brien Institute for Public Health Spring Forum. We've entitled this Evidence in Action, Community-Driven Interventions for Better Health Policies. I'm Paul Ronksley. I'm the Associate Scientific Director for the O'Brien Institute Health Systems Portfolio, and I'll be one of your co-hosts today. I'm really excited to see that you've decided to spend the day with us, and it's great to see so many familiar faces, but also a lot of new faces in the audience as well. We've packed a lot into this next 5 hours from about 9 till 2. But before we start, I'd like to recognize that the University of Calgary, located in the heart of southern Alberta, both acknowledges and pays tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Goodstoney First Nations. The City of Calgary is also home to the Métis Nation of Alberta, Districts 5 and 6. When I think about reconciliation, I know it means different things to all of us. And for me, as a settler, I recognized the need to learn, and I often found it really difficult to know where to start. And fortunately, I have a really good colleague and friend, Pam Roach, that gave me a copy of this book, 21 Things You May Not Know About the Indian Act. It's written by Bob Joseph. It's a really eye-opening read, a really quick read as well. So this gave me a really good starting point for my own learning, and I put this up there just if anyone's looking for a resource for their own learning. At the same time, I feel this obligation as a parent to teach my children about what I've learned, what I continue to learn, and at the same time to be grateful to be able to live and play on this beautiful land. And I've put up 2 photos as well, one from my neighborhood just down in Silver Springs, that's Beaumont Park, and the other one in the mountains where our family spends lots of time. And so I'm very grateful to grateful for those that have protected this land for centuries. At this point, I'd like to introduce Elder Jackie Bromley up to the stage to provide us with a welcoming address and to open our event in a good way. For those of you that don't know Elder Jackie, she's used her voice to remove barriers for historically marginalized people in Canada for over 30 years. Elder Jackie is a Blackfoot woman and a strong advocate for housing and health for urban Indigenous people. She's very active in the community and serves on boards for organizations including the Awotan Healing Lodge, Alberta Health Services, the University of Calgary, University of Alberta, and the Alex Community Health Centre. She's also received many accolades, including the Queen Elizabeth II Platinum Jubilee Medal, and she was named one of last year's 20 Compelling Calgarians for her community involvement. So please join me in welcoming Elder Jackie Bromley to the stage.
Okay, first of all, I would like to say good morning. In my Blackfoot language, we say "Itamikskanyatone," and I'm always so honored to build that relationship. To me, it is so important, and one of the things that there's 2 things I never leave out. First of all is every morning, no matter how busy you are, always give thanks to the Creator we call Source of Life. You give thanks to the sun, Nabinatushi. Today we're all in here. The Creator gave us another day. Each and every one of us, I was sitting there listening to, hearing people talk about what field they're in. And I sat there thinking about it. I'm very proud of you guys, very proud of you. But always remember, before you start your busy day, to thank the Creator for the gift that the Creator gave each and every one of us in here. And part of my culture, the teachings that I receive from my elders, we have 7 natural laws. The 7 natural laws is to love one another, to be honest, and to be humble, and to respect one another, and to tell the truth. We talk about reconciliation. I seen it there. This is what I call reconciliation, building the relationship. And before I start my prayer, I would like to share with you that I have a common teaching from many of the elders, is that as human beings, we did not just arrive in this time and place on our own. We carry the life stories and lived experience of our ancestors and those who have preserved so that our generations can live life in a good way. Our stories carried in the land, in the rocks, in the rivers, in the whole environment, coexisted in such a way that there was harmony between all beings within creation. We were capable of seeking treaties with each other to preserve life. It is those thoughts and peaceful energies that we breathe life into when we do the land acknowledgement. And I would like to say my prayer. It's going to be in my Blackfoot language. The elders have always told me it's always good to start off in a good way. Okamanishta, the Creator, for guidance, for support and direction. We must never, never leave out the homeless people, because that's one of the topic for discussions. Must never leave out all the generation today that are using drugs. In our culture, we say their spirits have left their body. And with every one of us in here praying, we're asking Creator to bring back their spirit, because they don't even know what's right or wrong. And I would like also to pray for your children, your grandchildren, and your parents and your grandparents. When we pray all together, it makes our prayers very powerful. And I always say the Creator, we call, works in mysterious ways. And I will start my prayer. I've been offered tobacco. And if you could just pray along with me in your own way of praying. There's no special way of praying. Just speak to the Creator from your heart. Ayus tibeta piyok. Ayu na pinatuse. Ayu kita kokits pomok spinunan oksistikoy. Nokpikim mo kinunak. An oka muksi chip stopikse. Makpokanesak sa sukapi. Gam stokshaikimat kuyimix. Estistomix. Nuku sinonix, nesuku sinonix. Ispomusa istipeta piok. Oke imene. Anachishinski domina apuyaki makka. Kitkanet skatopua. Makko kipstopapa keisi suki kimstan. Makita pesuki kimsta tuusa an uhtaksi puissa. Kenekin nohkanistuka manistaki sipeta piok. Nohkaistukin nunak. Kiako kita spumuk spinnunan ohkamuksi. Nitpukkanawatse skamek. Anya. Thank you everybody and have a good morning.
Thank you, Elder Jackie, for the beautiful words, for setting the intention for today, your thoughtful words, and we're really appreciative of your time and your involvement in today's event. I'd like to show, as I had mentioned before, we have a very packed schedule for the afternoon here. And so this is what our agenda looks like. You'll also have a copy of it on your table, and I believe you probably have it in your email as well. But just for a bit of context, the mission of the O'Brien Institute is to advance public health through research excellence. And today we're going to be focusing on how we can address this mission through policy trials and working with community partners. We're hoping that today's event will help build capacity and encourage the use of policy trials, but at the same time we want to create new partnerships with researchers and community organizations. And along this route, we want to highlight some successes that we've had. So putting on these events is no easy feat, and I just wanted to recognize the planning committee members, the O'Brien Institute Center for Health Policy, the Health Policy Trials Unit, and our community partners, Vibrant Communities Calgary and the ALEX. I'd also like to introduce Tessa Pennick up to the stage from Vibrant Communities Calgary. She's going to be co-hosting this event with me. Tessa serves as the leader of organizational effectiveness at Vibrant Communities Calgary and also leads VCC's research strategy. Tessa's past professional experience includes frontline work supporting victims of domestic abuse and sexual violence, and advancing Alberta's living wage movement. She's also passionate about effective leadership, operational excellence, feminist research, policy advocacy, and nonprofit governance. She holds a Bachelor of Arts in Sociology and Women and Gender Studies from the University of Lethbridge and a Master of Arts in Legal Studies from Carleton University. Join me in welcoming Tessa up to the stage.
Good morning, everyone. Thank you all for joining us. Thank you, Paul, for the introduction, and to Elder Jackie for starting us off in such a good way. My name is Tessa Pennick. I'll be one of your co-hosts today, and I'm really excited to represent Vibrant Communities Calgary at this event. Thank you to the Planning Committee, the O'Brien Institute for Public Health's Center for Health Policy, Policy Trials Unit, and the ALEX for bringing us together today. Vibrant Communities Calgary is the steward of Enough for All, Calgary's community-driven poverty reduction strategy. We work to move the needle on poverty through evidence-based policy advocacy, research, community engagement, and public awareness. Poverty in our city isn't a single issue with a simple fix. It's layered, systemic, and deeply rooted. So here's the real question of our work. Who has the power to change it? Not one organization, not one sector. It takes all of us. That's why VCC works with over 70 community partners, including many of you in the room today, plus numerous Calgarians across sectors who care about reducing poverty. Our frontline client-serving partners have insight and on-the-ground expertise that shapes our research and advocacy moving the needle on poverty. Collaboration isn't just a nice to have, it's the only way forward. Today's event is rooted in this simple idea. Better policy happens when researchers and communities work together. When we connect the rigor of academic inquiry with the realities of lived experience, we can design smarter and more sustainable policy interventions. We also can discover what changes make a measurable impact on the lives of real people. That's why today isn't just about sharing findings or launching projects. It's also about building trust, making connections, and hopefully laying the foundation for long-term collaboration. If we want to move the needle on complex issues, we need more than just individual expertise. We need alignment, coordination, and a shared commitment to work across sectors. This is more than just research for research's sake. This is research focused on practical, measurable change. And the work isn't always straightforward. We know that it takes time to build partnerships that can handle the nuance and messiness of real systems change work. But those relationships are what make this long-term change in our community possible. Whether you're here today as a researcher, a practitioner, a policymaker, or a community leader, I hope today gives you something more than a set of insights. I hope it gives you new connections, new questions, and new partners for the next phase of your work. Now, I'm very excited to introduce Dr. Amity Quinn. She is a health economist and an assistant professor in the departments of obstetrics and gynecology and community health sciences at the University of Calgary. As co-director of the Health Policy Trials Unit, she focuses on using experimental and econometric methods to study health system performance to improve care for women and other vulnerable and marginalized groups. Please join me in welcoming Amity to the stage to say a few words on policy trials.
Good morning, everybody. I'm so excited this day is finally here, and thanks to everybody who's made it possible and for you for being here. Okay, so there's a lot of words that are going to be coming at us today, like RCT, pragmatic trial, experiment, and I thought we should all make sure we knew what we were talking about when we heard these words. So when we're saying policy trial, how we're defining it today is up here on the screen, thinking about a randomized evaluation of the effectiveness of a policy or program, often applied at a group level in a real-world setting. So this is different than a clinical trial where you're maybe testing a drug and giving one person one dose and one person gets a placebo. We're thinking about bigger changes, whether it's from a government change or your community organization changing something they're doing with their staff or their clients. So, but the key element is that we're doing it's a randomized experiment. So I hope that helps all of us know what we're talking about today, and people might use the word pragmatic trial. That has the same concept of doing these experiments in a real world setting more than like a controlled kind of lab setting, like we might think about when we're saying clinical trial. Okay, so with that out of the way, I would like to welcome our first keynote speaker, Dr. Claire Boone. Claire is an assistant professor at McGill, and she's a health economist who studies health and healthcare decisions using experimental and quasi-experimental methods, machine learning, and behavioral science. Her current research examines how behavioral biases affect decisions in primary healthcare, how we can use AI to improve outcomes in emergency departments, and the consequences of value-based payment models. Before joining McGill, she completed a PhD at the University of California, Berkeley, and a postdoc at the University of Chicago, and worked as a clinical research scientist at the Providence Health System in Oregon. All right, and I'd now like to welcome Claire up to the stage.
Hi, everyone. Thank you so much for having me, and thank you to the organizers. I am so excited to be at a day that is completely devoted to health policy trials. As someone who works in this space, I think this is quite a rare opportunity, and I love the coming together of researchers, community members, and community organizers. See if I do this right. Okay. So thank you for the introduction, Amity. I'm Claire Boone, and today I'm going to present on harnessing big data and policy evaluations for learning health systems. So there are a lot of different definitions of what a learning health system is, But my favorite one is very simple, and it's that learning health systems embed research into healthcare. So today I'm going to share some of my experiences working as an embedded researcher in a couple of different health systems. In a couple of different health systems. And I think of research that attempts to improve healthcare delivery or the quality of healthcare as sort of broadly falling into one of three major phases that I've outlined here. So first, we may conduct a randomized trial. It could be a randomized policy trial or a randomized clinical trial, but it's generally pretty small scale. We're trying to understand the efficacy of something. Then, ideally, if that trial works out, we would like to scale up that intervention. So we want to implement it more widely so that it can improve the lives of more people. And then probably because we had to change the intervention a little bit from the small-scale version to the at-scale version, ideally, we could also then conduct a policy evaluation of that intervention. And we can do that using something called quasi-experimental methods. So these are methods that use sort of existing variation in the world to try to get at causal effects. So I'm going to use a few words like difference in differences, stepped wedge trial. Those kind of fall into this bucket of policy evaluation. So of course, this is quite a simplified and very idealized framework. It's very rare that one piece of information is going to flow through this whole pathway. But I'm going to use this framework to sort of organize my ideas today in this talk, and I'll talk a little bit about my experiences conducting both randomized trials and policy evaluations. So I'll begin by describing some ongoing work on what is actually a clinical trial, and I really appreciate this definition that you gave. I'll explain in a little bit later why this is a clinical trial and not a policy trial. But this is a project where we are implementing an AI algorithm in a few emergency departments and trying to see if that algorithm can aid decision-making around whether a patient should be tested for heart attack. On the other end of the spectrum, I'll share some of my work conducting a couple of different policy evaluations, that is, measuring the impact of interventions that have already been taken to scale. So the first one I'll talk about is this evaluation of a national primary care appointment reminder program. This was in partnership with Chile's Ministry of Health, so they have a very large public healthcare system. And they actually did take a piece of evidence through this whole pipeline. So they piloted something, it worked really well, they scaled it up, and then they partnered with us researchers to come in and evaluate that scaled up intervention. And I really like this example because we're gonna see that there can be a really big difference between, I have a point, it doesn't really work. There can be a really big difference between efficacy, or the measures you get from a small-scale trial, and effectiveness, or the measures you get from something after it's been scaled up. I'll finish by discussing another policy evaluation. This one's in partnership with a large healthcare system in the US. And they, like many healthcare systems, are trying to incentivize value rather than volume of care right now. And they're doing that through paying bonus payments to physicians, accompanied with quality metrics. And in this project, we're basically evaluating whether those quality metrics do what we think they do. And as a bit of a teaser, we're finding some very unexpected results and some unintended consequences of these metrics. Okay, so going back to our clinical trial, HeartSpot, this trial aims to address the problem that some heart attacks are missed, even in emergency departments, and these are often deadly. So what I mean by missed is in our data, we can see that patients sometimes present at the emergency department in the early stages of heart attack, but ultimately don't get tested for heart attack. They end up being diagnosed with something else and being sent home, and this is very often a deadly situation. And so something I learned as, the non-physician on this project who didn't have a lot of understanding of like what a heart attack really is or what it looks like, is that that very specific image we have of someone having a heart attack that we see in movies and TV shows, where it's probably an older man clutching his left arm in pain. That is only one of many different ways that heart attacks can manifest. And so in reality, there's a huge suite of symptoms that can signal that someone's having a heart attack. And unfortunately for the physician who's trying to discern, should I test this patient or not, many of those symptoms are extremely general. So the patient might be having nausea, they might be having dizziness, that could be a heart attack, but it could be 100 different things. So the insight of one of my co-PIs on this project, Ziad Obermeyer, was that he was able to figure out, using a lot of big data, that physicians sometimes overweight these very salient symptoms like chest pain and shortness of breath and male sex compared to the actual predicted risk of those symptoms. And at the same time, they underweight different symptoms, such as a woman feeling dizzy, compared to the actual predicted risk of those symptoms. And this leads to sort of a suboptimal allocation of tests across patients, where we can see in our data, we've done this at a couple of different health systems, systematically, there are very low-risk patients who end up getting tested who really didn't need to be tested, and there are very high-risk patients who don't get tested who should have been tested for heart attack. So our solution in this HeartSpot trial is to build an AI or ML algorithm to try to help ED physicians with this decision. So instead of just relying on the human brain, which we know sort of overweights different symptoms and underweights others, and it can only hold so many pieces of information at one time, our model is able to take in about 5,000 different pieces of information about the patient's clinical history and current vital signs, and then give a pretty accurate predicted risk of, is this patient likely to be having a heart attack right now, and should they be tested? So I'll give you a little bit more insights about this model because I think it's cool. And specifically, we actually do 2 different predictions in this model. And this is like a general concept, I think, that can be applied to things other than heart attack. So we have historical data from emergency department encounters, about 5 million encounters from 2.6 million patients. This is like 8 years of data from one large health system. And what we do is separate that data into people who were tested for heart attack and people who were not tested. So among the people who did get tested, we want to predict, was their test positive? That signals that they were definitely having a heart attack. Among the people who were not tested, we want to predict, did they go on to have a major adverse cardiac event in the few days after their ED encounter? And the reason we want to do that is because we know that physicians allocate these tests imperfectly. And so if we just predicted, given testing was someone positive, we would be systematically missing all of those patients who didn't get the test. And that's exactly the kind of person we're trying to help with this trial. So we have all of this, large amount of data from a large number of people. And what we do is construct about 5,000 features or different variables that we throw into our model. There's a lot of different approaches you can use here. We decided that the more is more approach would work for us. So we basically made everything you could possibly think of into a variable. So we have the full history from each patient, and we make variables like, have they ever been diagnosed with diabetes? Have they ever been prescribed this very specific drug at this very specific dose, et cetera? And then we combine those with the vital signs that are taken at the current ED encounter and their chief complaint. So for patients who've never visited our health system, who don't have that long history, we're still able to make a reasonably good prediction about them because we're combining their current vital signs with all of this other information from the population. So to test whether our model is efficacious, we are currently designing and starting up a randomized clinical trial. We're very actively working on this design. There were a bunch of things that literally changed yesterday when I was on the plane. This is because we're working super closely with health system leaders, with ED physicians, with cardiologists, with patients in this health system to, really finalize the design. But I'll tell you where it's at right now. So our current plan is we're going to have 2 study sites, and we'll get model predictions for every single patient that walks into that ED. And then only for the very highest risk group, something like the top 3 percentile of risk, we will then take those patients and randomize them to the treatment or the control group at the patient level. And that's what makes this a clinical trial as opposed to a health policy trial, because we're really delivering it at the patient level, which I'll talk a little bit more about later. So for patients in the top highest risk percentile, if they get randomized to the treatment group, we're going to communicate the HeartSpot score to their ED physician, and we hope that will kind of spur them to get tested for heart attack. And for patients randomized to the control group, it'll just be care as usual, and they won't receive any additional information from us. So because we're randomizing at the patient level, we're hoping to have enough power that our primary outcome is going to be mortality. So we hope that this intervention will actually reduce patient mortality in the short term. And then, of course, we're going to have a bunch of sort of secondary and intermediary outcomes, different things that we would like to see change. If mortality is affected, we think these other things should change as well. So we'll also measure major adverse cardiac events. So it's possible that you had that, but you didn't actually die, so you're not showing up in the mortality. We'll measure physicians' decisions. Did they agree with the model? Did they deviate? And then we'll also do some physician surveys to understand, what do they think of the model after it's been implemented, their uptake, their feedback, et cetera. So because this is a really, in-progress trial, I unfortunately can't share any exciting results with you, but what I'm going to do instead is sort of share a few key lessons learned that I and my team have learned a couple of years into this project. So first, because we're implementing quite a novel technology, this was the first augmented AI tool to be sort of embedded within this healthcare system for research purposes. There has been a lot of learning around, how comfortable are people with that and how sort of conservative should we be. And so something we landed on is deciding to have a human in the loop at all times. So we're going to hire a study physician who is not someone in the current ED, who's going to be reviewing the algorithmic scores for every single patient. And she can actually choose to decide that one of those scores is wrong. So we've decided to do this because there's a lot of literature showing that sometimes if you implement an algorithm, people start to over-rely on it, and you sort of go into this not thinking as deeply mode, and you just do whatever the algorithm says, and it can actually worsen the quality of decisions than if you didn't have the algorithm there. And the other reason is, we of course wouldn't want it to be where something happened to our data, like data set drift, and now there is, the predictions are bad. So this is kind of an interesting decision from a design standpoint, because you may remember I just spent a bunch of time telling you that physicians often make this decision wrong. The whole point of this algorithm is to try to reduce that incorrect decision-making by the ED physicians, but now we're adding an ED physician back in who's looking at the algorithm. We think it's still worth it from a safety perspective, and this actually caused us to kind of completely change the design of our study. So at one point, we wanted to reduce low-value testing, so unnecessary tests among people with low predicted risk, and increase high-value testing. We realized that after we added this human in the loop, it would be very hard for this physician to look at a patient who traditionally would have been tested, but our model is saying not to test, and have her not override the model. So we basically scrapped that entire part of our study. This is an example of how you really need to be nimble when you're doing one of these trials. And we've decided to only focus on the high-risk patients because we think it's unlikely that this human in the loop is going to say, no, I don't think that patient should be tested, because it's a lot easier to say, yes, they should be tested. Second, because we were one of the first to start building an AI model in this health system, there was a lot of sort of data engineering learning we had to do. It turns out data is not stored in like one cloud, it's stored in 20 different clouds, and you need to get all of those to talk to each other. I'm seeing people smiling and nodding against that. So, we have like 7 VMs that talk to each other just to get the data from one place to another. Another thing we learned was it's of course very important that the inputs to your model, like your features, are representing reality. And so we had this situation where in some years, which were the early years when Epic, this is the Epic health system, the Epic EMR, the early years of Epic, the data was kind of funky and not exactly what we thought it would be. So we came up with this quality control mechanism where every couple of weeks we randomly pull some data and we compare the variables that we've created to physician notes. And so we think these should align, but they're completely different sources of information. One is being created from sort of the electronic medical record where someone inputted the value of a test. The other one is the physician documenting on their own, like, oh, this person tested high for this thing. And so now we periodically make sure those things align. Another really big lesson we learned is about how to balance scalability versus efficacy. So our original design for this project was to make it a very small nudge, something that pops up in the EMR, that we knew wouldn't be like a very strong effect, but we wanted to implement it on a very wide scale. And we really liked this because we were thinking, if the health system goes on to scale this up, this is probably what it would look like, and why don't we just test the thing that they're actually going to scale up? Through talking to people, we realized, there's a lot of ability to ignore things that pop up in Epic. I think there's a lot of decision fatigue over these different pop-ups. And we decided it was probably more valuable to really focus on a proof of concept design. That's kind of the opposite of what I just described. So we're going to do it much smaller scale at just 1 or 2 hospitals, but try to have a very strong effect size. So our study physician will be communicating, potentially calling or paging the ED physician, and we think that they're much more likely to sort of react to that nudge compared to this small thing popping up in the EMR. Ideally, our long-term ambitions are to, test this proof of concept version. Hopefully we find that the algorithm does what we hope it does, and then we'll alter the design and hopefully have the health system scale it up. And then we would like them to do that in a way that allows us to evaluate it using something like a stepped wedge design or difference in differences. So my last note is a little bit more personal for researchers and especially early career researchers like myself. So it has been so incredible to be embedded within this health system. I've learned more than I could ever possibly imagine. One of the things I have learned is that this kind of work is incredibly slow. So we are projecting having results ready in 2030. When you are a researcher and assistant professor, we live in the unfortunate reality of you have to build your CV out, you need papers to get grants, et cetera. So something I have learned is that it's really important to pair one of these really ambitious long-term projects with things that can produce outputs more quickly. And for me, those are secondary data analysis, things using existing administrative data. So next, I'm going to discuss one of those policy evaluations. And this is a program piloted by Chile's Ministry of Health and then scaled up nationwide. And so in this case, our work as researchers was not in implementing or designing it, but just evaluating something that had already happened. And I wanted to discuss this non-randomized evaluation at a health policy trials meeting. because I think it's a really good example of evidence to action in the real world. And because in my experience, health system leaders, community members, et cetera, often want to know if this thing that already exists is working. And the best way that we can do that is through conducting a rigorous policy evaluation. So the problem that the Chilean Ministry of Health was hoping to solve was one of missed appointments. So in their health system, preventative care appointments are very frequently missed after they've been scheduled at a rate of about 17%. So their solution is one that has been, implemented many, many times before, which is, why don't we remind patients about their upcoming appointment using a text message reminder? Again, we have a really large data set here because it's a national public healthcare system. And we have about 300,000 patients who are affected. And interestingly, they decided to really focus on the group that they thought were the highest risk of missing their appointments. And so those are patients who have all been diagnosed with either hypertension or type 2 diabetes. So luckily, they rolled this out with variation over time. So primary care clinics basically implemented this software that would send out reminders at different points in time over a couple of years. You can see that in this graph here. And so as an academic, we get really excited about this because this allows us to do a difference in differences style analysis and get at the causal effect of this intervention. And so we found that these reminders did, in fact, increase attendance at preventative care. So for patients with type 2 diabetes, they were about 4% more likely to attend their scheduled appointment. And patients with hypertension were about 7% more likely to attend their scheduled appointment. Interestingly, when we brought this to the Ministry of Health, thinking, we were done with the study, we had found a positive effect, exciting, they were extremely disappointed with the results because they had been reading the very large literature on appointment reminders. And they said, the numbers you're finding are a lot smaller than what we've seen in the literature, what's going on? So we spent some time, explaining the difference between a small scale clinical trial, which is what most of this literature consists of, and how that's probably going to have a stronger effect than something when you implement it at scale, which is what they had done in their setting. This was a super interesting discussion, and it led us to finding out from them that they had heard that some clinics were having trouble implementing this software. And so what we did was go back to the primary care clinics, there's about 300 of them, and collect phone records to try to understand, were patients actually being sent the reminder if they were supposed to have been sent it? So to our surprise, we found that only about 53% of eligible patients were actually sent reminders. So that's the average. There's a lot of variation sort of across clinics and over time, and that's what I'm showing in these graphs. So in the beginning of 2015, right when it was implemented, some clinics are doing very well. They're sending about 75% of reminders, but others are sending 0 reminders. So in our data, we had classified them as treatment equals 1 in our ITT analysis, but in fact, they were not sending any reminders at all. If you follow the peaks, you can kind of see that implementation seems to improve over time. It remains, a lot lower than I would think this kind of intervention would have. But what we heard from people working at the primary care clinics was they essentially just didn't have phone numbers for patients. But before this intervention, they had no reason to have them. So, all of a sudden you have this software, but you don't have phone numbers to put into it. They basically had to wait for patients to trickle in until they could collect the phone numbers. So after we incorporated this into our analysis, we almost completely closed the gap between our results and the RCT literature. So the 50%, adding the 50% compliance kind of almost doubled our results. And we then found that patients with type 2 diabetes were 9% more likely to attend their visits, and patients with hypertension were about 11% more likely to attend their visits. Okay, this is the last study I'll talk about. I don't know how I'm doing on time. Good, okay, thank you. So this is another policy evaluation. This one is joint with a large healthcare system in the US. And here we're evaluating the impact of quality metrics coupled with bonus payments. And the motivation of this study is that payment structures that incentivize value over volume are increasingly common, not just in the US, but there are several provinces in Canada, notably Quebec, which is where I live. They've been talking about adding, some incentives into family doctors' contracts that basically move away from fee-for-service, where the physician can make more money when they do more tasks, and trying to incentivize, specific care processes or health outcomes or different things like that. So these have been implemented quite widely already in the US, despite in the US, there is mixed evidence on their effectiveness. So of course, this has worked very well in other places like the UK, but so far in the US, we're not really sure how this is doing, but we're implementing it very rapidly. And at the core of many of these sort of value-based payment models or pay-for-performance schemes is quality metrics. And these are goals that the physician should hit. And if she does, she usually gets some kind of bonus payment. So in this study, we're able to isolate the impact of just one quality metric. And that one is for hypertension control. So specifically, this is kind of a unique scenario because the health system added some quality metrics into the physicians' actual employment contracts. So most of these physicians are employed by the health system. They get a letter saying, this is your salary, et cetera. But now there's this new thing where they say, if you achieve, if this threshold of your patients who have hypertension achieve hypertension control, which is defined as blood pressure less than 140/90, you will get a bonus of about 3% of your salary. So I think that's quite a large amount of money. These people are paid pretty well. I think that it works out to like $9,000. So it's this unique situation where it should be very salient to the physician because it's directly going to them instead of going to their practice or something like that. And just like in the last policy evaluation, we were very lucky that that they happened to implement this at different times in different regions. So we're able to harness that variation and do, once again, a difference in different style analysis to try to get at the causal impact of this quality metric. Oh no, you can't see my histograms, which are a big part of this thing. Okay. I'll try to describe them, which is much worse. I don't know what happened. Okay, so the first thing we did in this project was, I'm a big fan of just looking at your data descriptively for a while before you do any sort of real statistics. So the first thing I did was plot the distribution of blood pressure, and I was thinking, maybe it's going to shift one way or another if this quality metric is working. What I found instead is there were some clinics that have the expected distribution of blood pressure. So that's kind of like a normal distribution, as you have with basically any human biomarker. And there are other clinics where they're basically missing people in the range just above the threshold for control. So instead of a smooth distribution, you have this like big chunk of people missing in the area from sort of 140 to 150. The question now is, can we figure out if that's an improvement in patient health? So maybe these people are really motivated by their physician who's been incentivized to reduce their blood pressure, and they used to come in and test at 145, but now they're testing below 140. Or is this actually driven by changes in provider behavior? So maybe they're measuring differently, maybe they're reporting differently. Something that, if you could see the histograms, there are some clinics where there is just an absurd number of people at 139. So that was our first clue that maybe this is not something, real and biological that's happening. Maybe it's actually a change in reporting. So a really great feature of the data we have from this health system is we are able to not just see the blood pressure that was reported as sort of the final number by the physicians, but we can see every single blood pressure that they took at that encounter. And so the first thing we do is we find out that the quality metric leads to an almost 20% increase in the probability that these patients have more than one blood pressure taken at their primary care encounter. This is good news because the clinical guidelines say you should always have your blood pressure taken more than once. Blood pressure varies a lot within a person over a short time period, so we usually don't trust one measure. We want to take a bunch and average them. In practice, often there's not enough time in an encounter, and in most cases, people are just taking one measure in our data. And so the first thing that this quality metric does is really increase the probability that patients have more than one measure. We're also able to document the variation, so there's up to about a 10-point difference in one person's sort of highest and lowest blood pressure value. And then we can see that the provider reports the lowest value 80% of the time. So it doesn't seem like they're averaging and reporting the average. They're basically measuring a few times, and this happens more when they have the incentive. They measure a few times, and then they report the lowest value. So this leads us to believe that it's this change in remeasurement or sort of selective remeasurement conditional on first blood pressure reading value that is giving us the mystery histograms that you cannot see. So then the question is, how does this increase in remeasurement affect patient care and ultimately patient health? Because that seems to be kind of like the main mechanism that happens with this quality metric. And so what we do next is estimate the impact of the quality metric using our difference in differences analysis, both among all patients who have hypertension. Again, this is a lot of data. So we have 770,000 encounters from, I think, 300,000 patients. So we do our results for everyone, and then we also do our results for a subset of patients, specifically those who initially tested marginally positive. So you could imagine that from our previous results, we know your first blood pressure is usually higher than your second. So if your first blood pressure is 145, and now your physician is more likely to remeasure you because of this quality metric, your second measure might take you from 145, which is considered uncontrolled hypertension, to 138, which is considered controlled hypertension. And so our question is, if this, one, is this going on? And two, now that the provider is potentially getting these different categories of this person is sort of controlled but sort of uncontrolled, how do they treat that patient? So we find no change in initial blood pressure, but we find a large increase in the probability that patients' reported blood pressure was under 140. So it's not statistically significant in the overall group, but in the marginally positive people who we sort of think are going to be most affected by this quality metric, they are 20% more likely to end up being reported as under 140. And this drives the histograms that you could not see. This also leads to quite a big increase in what I'm calling workshopping discordant hypertension, where you have one value that says this patient is controlled and another value saying this patient is uncontrolled. And to understand how these physicians are thinking about this situation, which becomes very common after the quality metric is implemented, we look at medication. So correct me if I'm wrong, if anyone here is a primary care physician, what I have learned talking to folks is that if you have a patient with hypertension who is already on medication and is uncontrolled, one of the first things you're going to do, in addition to counseling them about making sure to adhere to their meds, change their diet, et cetera, which those are things we cannot see in our data, unfortunately. One thing that you would maybe do that we can see in our data is you might just up their dose of their existing medication. And what we find is the quality metric reduces the likelihood by quite a lot, about 15%, that patients receive any kind of intensification of their existing medication or get prescribed a new medication. So this is kind of indicating to us that the quality metric increases remeasurement. That seems to move some people from the uncontrolled category to the controlled category, and now they're not getting medication updates that they would have gotten absent this quality metric. So the last question is this a good or a bad thing? It could really go either way. It could be that people are on average overtreated and not updating their meds is a good thing, or it could be that we're withholding sort of life-saving medication from these people. So the last outcome we look at is, were these patients hospitalized for acute cardiovascular events in the year following this primary care encounter? We treat hypertension not because it has symptoms, but because we're trying to reduce sort of overall cardiovascular risk. And we find that for these marginal patients who are most affected by the quality metric, they are more likely to be hospitalized for stroke or acute coronary syndrome in the year, 6 months, or 3 months following the implementation of this quality metric. So it does not seem to be a good thing that their medication is not being increased. And so this is like a very unintended consequence of incentivizing hypertension control in this population. So that was all my results. The last paper is sort of in progress. I haven't communicated the results back to the health system yet with the addition of the cardiovascular stuff. But from economic theory, we could have predicted that when you incentivize a threshold like this, it's going to become very salient to the provider and become a goal that may or may not necessarily be a good thing. And there's lots of other examples of, quality metrics becoming goals that end up not actually improving care from other parts of the literature. And then I just wanted to finish by saying, I think both randomized trials and non-randomized policy evaluations are super important parts of this evidence to action pipeline, and they can work together to support learning health systems. And thank you. Looking forward to your questions. No, but I can hear you. Yeah. Yeah, so what we found in our preliminary analyses is there are people who we can predict are extremely high risk that don't get tested. So that's the exact group that we are trying to target testing for. And then the 3% threshold, we're moving that around just kind of based on how many patients does that mean we're randomizing and how much can the ED really handle us intervening with them per day. Yeah, I can't, unfortunately. This is like one of the black box things of machine learning. So it's some combination of the 5,000 pieces of information that we have on the patient that allows us to know they're going to be high risk, and that's something the doctor can't see. Yeah, but so I've been going back through and like reading the physician notes to kind of see what happens in the encounter for some of these patients, and it's hard because the physician who's writing the note doesn't think the person's having a heart attack, so they're kind of like selecting pieces of information that don't say heart attack, but it's shocking. I mean, in some cases, the patient has, even to my untrained eye, like lots of clear risk factors, and they just end up being diagnosed with like pneumonia or something else, and then they get that treatment and they get sent home. Yeah. Hi. Uh-huh. Yeah, so I presented this to some C-level people before I had the cardiovascular result, mostly focusing on like the changes to remeasurement and these weird histograms that were coming up. And they basically said, you know, we don't care. Like, we know people care about, like, when you incentivize something, they will do it. And I think this specific quality metric of hypertension control is so widely used that they are just assuming that, you know, even though this measurement behavior and reporting behavior changes, like that's fine. They're kind of doing what we want. The physician's maximizing her own payment by reporting the lower value, and, you know, it doesn't matter too much to the patient. But I haven't shown the actual health outcome results to them yet. They're like very fresh. So I hope they will change it. My dream is that they will let me move the threshold from 140 to 130 for some regions and basically test whether that is better. Yeah. Yeah. It was a US health system that I will not name. Yeah.
I was wondering, this is working. In these kind of studies, how do you kind of prevent, or do you see like incentivization of picking certain patients to accept into your practice? So like, what if you had a physician who was like, I'm gonna only accept people who, you know, I think can get them right down from like this slightly higher,
Yeah, I think that is possible, and if anything, for us, it would probably be attenuating our results because they're like purposely not taking the people they can't change. I fix the patients, so there's not like new patients flowing in all the time into the study, but I do think, you know, in this kind of health system, or, you know, in the US where there's a lot of different options, people absolutely have choice over their primary care provider, and some providers, I think there is evidence that like this cream skimming for sure happens. So there's a lot of ways to kind of like maximize your own payout from a quality metric, and this is one of them. Yeah.
I'd assume in most of these clinics, it's the nurses doing the blood pressure measurements. So where are nurses in this conversation?
Yeah, that's a really good point. So we can see if it's a nurse or a physician assistant or a physician doing the measurement, and I can, you know, drop different groups and my results stay completely the same. We decided to include all of them, all the different kinds of providers in this analysis, because anecdotally, what I have heard and what I can kind of see in the data is that if you incentivize a physician who works with a few nurses at her practice, the behavior of the nurses also changes. So not all the time, but in this data, it does look like after the incentive comes in, even though the incentive is only going to the physician, the behavior of the nurses around it, do they measure more than once, for example, also changes. which I think is quite interesting in itself. It does seem like a viable way to change the behavior of like multiple different people working in the clinic.
Why are nurses
Yeah, I completely agree. I don't know why they made this decision, but from what I can tell, they did not offer any kind of quality improvement incentive to the nurses. Yeah. We're good?
No, good.
Okay. Thank you.
Thank you so much, Claire. So we're going to take a 15-minute break now, and after that, we'll resume with the next session, Working Together, Successful Examples of Community and Academic Partnerships in Conducting Trials. And while you're on your break, a little bit later on, you're going to be moving around to tables, and you'll see there's a number on your name tag, and you will see there will be numbers on the tables. So you might just want to take this opportunity to check out where your table is for that session. So enjoy your break, and we'll see you back soon. Okay, our next session is going to provide some examples of these community and academic partnerships in action. So it's called Working Together, Successful Examples of Community and Academic Partnerships in Conducting Trials. And there's going to be a series of discussions about some different trials. But we're going to hold all of the questions about all of the different examples till the end, okay? So the first one is going to be presented by Dr. David Campbell and Emma Wisnick. Dr. David Campbell is a diabetes specialist and associate professor of medicine and community health at the University of Calgary. And Emma is a registered nurse and clinic manager of the Mobile and Youth Health Program at the Alex Community Health Center. She supports outreach and clinic-based services aimed at reducing barriers and enhancing access to care. So welcome, Dave and Emma.
Right. Yeah, so it's our pleasure to be here to tell you a little bit about the partnership that we have established between researchers at the University of Calgary and practitioners at the Alex over the last several years. So I'll maybe start by giving you a bit of the backstory on our partnership and our collaboration. My team had done a number of studies over the years that have illustrated and demonstrated that people that are experiencing homelessness and also simultaneously living with diabetes really struggle to achieve optimal health outcomes. And it's not entirely surprising, but we found that they were less likely to get all the screening tests done that they need to have done, and therefore more likely to have complications like foot problems, eye problems and blindness, and kidney problems that are undetected because they're not getting access to the types of screening care that they need. Throughout 2022, my team had actually piloted a project looking at whether we could bring screening closer to the community and embed screening processes within the shelter environment. And we did that with the drop-in center and with the mustard seed. And the project was quite successful, but we heard that the program would be much better if it could be made more accessible to others in the community, people who weren't necessarily living at the DI, but still facing many of the types of struggles that people had. And we worked with our lived experience group called the Calgary Diabetes Advocacy Committee. These are people with lived experience of diabetes and homelessness who told us that, once people get housed, they leave the homeless shelters, they still need these types of supports and accesses. And so we need to think of a way to bring it into the community and bring this one-stop shop approach to people more readily. We started looking into how we could do this and how we could bring it to the community, and heard about kind of integrated mobile care, and started thinking about how we might do that, and quite a daunting task to think about how do we start up a whole new mobile care program. But fortunately, I had a colleague at the time that I was working with who was the medical director of the mobile health program at the time, and he told me that, hey, at the Alex specifically, and he said, we've got some capacity on the bus and we should look at a partnership. And from there, I was put in touch with Emma, and I guess that was the genesis of our partnership.
Yeah, so that was about in 2023 that the physician reached out, and then Dr. Campbell reached out, kind of showing the details of the project and what that looked like, and especially kind of what the process had looked like at the shelters beforehand. So really, we looked at the focus sharing on improving access to diabetes care for those who often face significant barriers, and that was definitely something that, as a mobile care clinic and as a mobile health program, we definitely look at as a foundation of the work that we're doing. So what really stood out to us was the goal to not only offer screening, but build in the model of ongoing and comprehensive care for a lot of those clients. And the vision to partner with the community sites to offer dedicated point of care testing, as well as with the full care team. So a nurse, diabetes educator, and then endocrinologist to support those in managing their concerns longer term. So it was definitely a good starting point, working on that same goal of serving community members with that shared focus. So it aligned in kind of closely our values and mission at the Alex, especially with what we were trying to do with the mobile health program. So for us, the collaboration definitely meant that we could expand our capacity, particularly by offering point of care testing and streamlined follow-up for those who maybe wouldn't have access to that traditional healthcare system, or maybe wouldn't have access to that information previously. And it's something that we wouldn't have been able to do without the specialized team and equipment that the partnership had brought. So it was able to extend our reach and our scope directly into community settings and connecting with people that might not otherwise access those pieces.
And for me and my team, the partnership offered something that would have been completely impossible if we'd been working on our own. Being able to leverage the infrastructure, like the actual physical vehicles, and the expertise of the people that work at the Alex and had expertise working in mobile care for decades were things that we as an academic group could not have replicated. Without the partnership with the Alex, we would have needed heck of a lot more money to get started, and it would have been a much rougher launch than we were able to pull off last year when we started the program. In addition to just the physical and the human resources, which have been tremendous, the affiliation with the Alex also brought patients and people with the trust and rapport of working with a trusted community organization that people know and respect, and patients are happy to see us when they affiliate or associate our clinic and our program with the Alex. It would have been much more difficult, I think, if we didn't have that brand recognition and an organization like the Alex that has a reputation in the community.
Yeah, so as we started the process working together, it was definitely a learning experience on both sides as we navigated lots of different aspects of the primary healthcare system and what was needed, kind of looking at the primary health and the specialty care services. One big thing for us was we weren't working all on the same electronic medical record, so that did pose lots of challenges that we needed to navigate. But in addition, looking at figuring out logistics of transferring sensitive medical equipment on our mobile clinics. We spent our initial time refining follow-up workflows and addressing challenges that come with providing continuity of care in a mobile and community setting. So lots of our clients who may have difficulty following up or may not have attachment to healthcare otherwise, and making sure that we had those pathways for them, and we're very intentional with those. So for us at the Alex, it was important that we continue offering our full range of services during these clinics. We know that clients often come with multiple challenges, not isolated to these screenings, so we wanted to make sure that we were aligned and remain responsive to the overall health for these community members.
I think we were able to establish a very open and respectful dialogue from the outset. But that said, it was apparent, as Emma said, that while our respective goals were synergistic with each other's, there was not direct overlap in all issues and in all priorities. The biggest one for me was that as a specialty care provider, my focus is on people living with diabetes and making sure they get specialized care. And at the Alex, their focus has traditionally been on ensuring comprehensive primary care for their patients. And so this required a lot of flexibility and goodwill on both partners to make sure that this partnership would work and meet the needs of both. One example was, when we had first talked about this program and what it would look like, we realized that we needed to hire a nurse to kind of run the program, and I kind of figured this would be a nurse that would be hired and trained by me at the university or through the diabetes center, and we realized that a nurse that's hired and trained by me isn't necessarily going to have all the skills and resources to do primary care nursing and all the other things that the Alex team does, and so we realized that resource needed to really be hired, trained, and under the stewardship of the Alex. And so that was a piece where we had to build flexibility and make sure that we could flex things to meet both partners' needs.
So yeah, naturally there's some challenges that we look to overcome, and as mentioned, one of the significant challenges was electronic medical records. So at the beginning, which we weren't all on the same EMR because we were coming from different areas of the healthcare system. So it made it significantly challenging to document and communicate and do that information sharing. So coordinating care between team members and community members require those extra steps, and at times created gaps that we had to navigate and just in that communication piece alone. So we took some time and adjusted internal workflows to incorporate new equipment and care models. We also looked at hiring and training staff to deliver the specialized care in addition to the overall primary care that we were looking in our outreach model. And then, like many community-based programs, follow-up remained a challenge, especially for those who do have difficulty accessing like phones or transportation or things like that. So still an obstacle that helped us grow and kind of had a more responsive partnership in kind of both sides.
One of the biggest challenges that I noticed in our partnership was just around the timelines and the timeliness of things. And I think, as Claire mentioned in her talk earlier, this type of partnered embedded research requires time, and it takes a lot of time and effort to smooth out all of these issues that we're talking about. And I think sometimes as researchers, Claire mentioned that we're accountable to do things like get grants and publish papers, and therefore we often gravitate towards projects where we have all the control. We have the data set at our fingertips, and we can just analyze things and write the papers and get them out and tick our academic boxes. But a partnership like this doesn't work like that, and it requires time to build the trust and make those compromises and make sure that we're understanding each other, and so that both objectives can be met. I think looking back, if I'd had a strict timeline due to grants that were expiring or funding, we would have been in trouble. But we were able to build that trust over the course of writing a grant together and seeing it through and working together slowly over time to make sure that we ironed out these issues. It was really helpful. And looking back, there were times where I didn't really understand the problems that Emma was facing in her organization, and it took humility on my part to say, wait, I don't actually understand the environment that you're working in or the constraints that you're facing. And she's been very patient in teaching me and helping me to understand, the challenges that she's facing and that she's accountable for as well, and that their organization needs to ensure are being met. Just kind of, I know we're running out of time, but I want to talk a little bit about this idea of a trial, because the Alex has been such a great partner to work with, but it was clear to me from the outset that if I had approached them and said, we want to do a randomized trial of this intervention, it probably would have been a non-starter. I think there would have been a lot of issues that Emma would have raised and said, we need to work this out first and figure out all of the kinks that happen here, and that's exactly what we've done. And so we've done essentially a lead-in phase where we ran this program for a year to kind of figure out all the issues that would arise, to get us to the point now where we're able to start thinking about how does an RCT work and how can we work together to pull off a trial. We haven't figured out all the issues yet, and maybe I'm just going to talk about just some of the issues that we need to cross still in order to get our trial off the ground.
Yeah, I think briefly, one of the big things is kind of referrals and what we're trying to work on with referrals and having referrals kind of in place. So that's something that we are definitely looking at how we incorporate referrals. We did it internally first to make sure that we had a process in place, but really trying to streamline those communication pieces and having external referrals as a possibility to be able to come in, and then being able to support clients still within both the primary health and kind of the specialty care world.
So just in conclusion, I think we've been able to establish a very productive partnership and one that's worked really well, and we've still got more challenges ahead as we start to look to build our program and launch this into a randomized trial. But I think it's been a great model for me to work with a community organization like the Alex and realize all the places that we need to be nimble and flexible and willing to work together.
Okay, thanks, Dave and Emma. All right, our next presentation has some virtual guests. So it's going to be on a pragmatic trial of copayment elimination for high-value cardiovascular medications, presented by Dr. Braden Mans and Andrea Nagel. Braden is going to be joining by video, and Andrea will be joining by Zoom. So Dr. Mans is the professor in health economics and a kidney specialist at the University of Calgary. And Andrea is a pharmacist who worked for a number of years in the private sector, both in small community pharmacies and large chains in rural and urban locations. She's now the executive director of the Pharmaceuticals and Health Benefits branch of Alberta Health, responsible to provide leadership and direction to the team that oversees approximately $2.5 billion in government spending on community-based health benefits programs for Albertans. Okay, I'm a little nervous about this technology, but let's see. Again, click again, okay.
Hi, I'm Braden Mans. I'm sorry that I'm not able to be there with you today, but Dave asked me to tell you a little bit more about the Access study, which Dave can obviously answer questions. He was part of the study. It started actually even before Dave was a graduate student. But it's a health policy trial, and Dave asked me just to talk about some of the challenges, but also the opportunities of doing that, and hopefully encourage you to consider one. And I don't think there's specifically a roadmap that you have to follow, but the Access study was a study that came out of the Interdisciplinary Chronic Disease Collaboration. It wasn't funded by what was called Alberta Innovates Health Solutions at the time. Well, that was one of the places that got funding. It was funded out of CIHR as well. And actually Alberta Health was a financial contributor and major collaborator on the study, which took probably 10 years to finish. So the Interdisciplinary Chronic Disease Collaboration was about chronic diseases, and it had 3 phases. First phase, we were looking at trends in chronic diseases and management, and we knew that chronic diseases were increasing from administrative health data, and we knew that many people weren't receiving the medications that we knew could save lives and prevent complications. The second phase was actually then to survey Canadians. We partnered with researchers within the CCHS, the Canadian Community Health Survey, and we added some questions specifically about within the Western provinces among people with chronic diseases. And we found that about 20% of people said they had financial barriers to their medications. The third phase, so we had the administrative health data, we did the survey, and the third phase was meant to intervene on the highest priority gaps, try to test a solution that would overcome that gap and see if it actually improved adherence, get people out of the emergency room. And of course, if you're going to do a health policy trial to test a health policy, you'd better include some people from health ministries which do health policy. And so all along we've been working with Chad Mitchell, who was an executive director, I think, when this all started, Andrea Nagel, who eventually took over for him, and we were working with Min Alican, an assistant deputy minister at the time as well. And so what we knew was that chronic diseases were increasing. A substantial proportion, maybe a third, who should have been on statins, weren't receiving them. And that was just one of the medications we were interested in. About 20% of people said they had a financial barrier to taking their medications. We also knew from the US, from when they implemented Part D Medicare, essentially providing insurance for medications for seniors in the US, that use of statins, again, that's just an indicator of medication, but use of statins went up by about 30%. So we knew that it could be effective, and the government was interested in medications. We thought that the lowest hanging fruit, what we would love to have studied, would be providing insurance to people uninsured. So our donut of coverage, so to speak, in Alberta, our people who don't pay premiums, don't have medication coverage. The working poor, typically people who don't have medication insurance. So we proposed that to the government, and that wasn't their interest at the time. They thought it was risky, that what would happen at the end of the study would, they have to take would people coming off the insurance, that could be a problem. But through further discussions, they were interested in seniors. They were very interested in seniors coverage they provided to seniors, because seniors were vocal, and there was lots of complaints coming in, and they wanted to know whether complaints that coverage, that the co-payments, that was a burden, and they were interested in seeing what would happen if those co-payments were waived. So we co-designed a randomized trial with them, and they were willing to randomize people to waiving their co-payments. We got them on board, but we still didn't have sign-off. We needed them to basically create a new formulary and a plan that people could be randomized into. And it probably took 3 years from changing the name of the study to getting the study population right. And in fact, we finally got sign-off. We were at a meeting at the Banff Centre. Min Alican was there, and she planned to get me to talk to the deputy on a 1-minute walk from the hotel over to the conference centre. And I literally had the opportunity to do the sales pitch for the study. She'd been told about it, but she hadn't remembered much about it. And on the way over, I explained the study, what it was called, and what we needed from Alberta Health. And she said yes, and that got us what we needed. So those were the challenges. We finally got, we got funding. We had we had the formulary. that we can enroll patients into. Amazingly, at the end of this 3-year study, the intervention waiving co-payments didn't actually reduce complications, hospitalizations, death. So I guess that story is to say health policy trials are definitely worth doing. You definitely need to partner with governments. You need to build relationships and trust. And hopefully I've inspired you that these are possible, and that if you start working with people in the ministry right away and do a lot of listening, that they're possible. Good luck with the rest of the day.
Dr. Matt James and Karen Sullivan, so you guys can make your way up here. Dr. James is a clinician scientist with training in nephrology and epidemiology and a professor in the departments of medicine and community health sciences at the University of Calgary. And Karen Sullivan is a senior healthcare executive and licensed pharmacist with over 30 years of leadership in pharmacy, public policy, and system transformation across Canada.
Thank you, Amity. Thank you very much for inviting us and having us today to share our experience working together around a trial that's been evolving and coming together over several years. So I'll start and provide a little bit of background around what this trial is about, and start a little bit about my experience initially approaching Karen and her team from Shoppers Drug Mart to partner with a business partner, which was something completely new for me. And then I'll let Karen talk about her perspective from this group coming to her with this interest and how she found that. And then we'll move on a little bit to discuss about some of the things we've learned along the way over the last few years working together. So this trial, I think we have a little logo up there. It's called PAUSE, but it's a trial that's looking to try to improve medication safety for people with chronic diseases. So this is another project that's risen out of the interdisciplinary chronic disease collaboration, which Dr. Manns mentioned earlier. This is now an initiative that's funded through a grant that's very much focused on innovative and pragmatic clinical trials for people with chronic diseases. This is particularly focused on people with diabetes, kidney disease, and heart disease, largely cardiovascular conditions. And this is focusing on a topic around medication safety that some clinicians may have heard about, the concept of sick day guidance. These are many medications that we provide to patients have important long-term benefits. They reduce cardiovascular risk, like we heard about this morning. They lower the risk of complications from diabetes. They lower the risk of progression of kidney disease to kidney failure. And we've tested them very thoroughly in large clinical trials, and we know that they have long-term benefits on these outcomes. But they also can have adverse events, which may be more common in real-world populations outside of clinical trials. Sick day guidance refers to the fact that many medications that are protective for kidney disease or protective for cardiovascular events, when people become sick with an illness that makes them potentially dehydrated or volume depleted, they may be more prone to develop complications from these medications. And so common teaching in clinical practice is you use these medications, but if you develop an illness, physicians or nurses or other care providers will be taught to tell patients to stop taking those medications, put them on hold, wait till you get over this illness, and then hopefully resume them when you're feeling better. That sounds just like common sense, no problem, should be easy. However, it turns out to be extremely tricky to do. First of all, there's multiple medications. Which is the right medication to stop? If you're taking, 4 or 5 medications and they're in blister packs, how do you know which are the ones I'm supposed to stop? And if you're taught this, today, are you going to remember this 2 months, 3 months, a year down the road when a sick event happens? Then the other challenge is, well, what symptoms? What's enough to make me stop my medications or put them on hold? Is it this symptom? Is it that symptom? And there's recognizing when the right time to do this is. And the third component is, this is intended to be a temporary holding of medications, and sometimes this can be a confusing message to patients. We're saying, you should be adherent to your medications, take them, don't stop them. without telling us. And then we're saying, stop them sometimes when in these certain situations, but we want to make sure you start them again. So lots of research has been tried to implement this, but not a lot of it has been successful with very traditional ways of teaching. So we decided we were going to try to tackle this and evaluate it within a trial. And so we developed an intervention that would actually help patients self-manage their medications. There was a lot of initial work. Mo Donald's in the audience here with us in our group trying to decide how we would deliver this. We worked with patients, we worked with healthcare providers, including pharmacists, and eventually we ended up settling on the idea of building a digital health tool, essentially an app for patients that they could use to manage their medication. It would help them review their symptoms to determine if they had the symptoms that should prompt them to hold a medication or not, and would also help them identify which medications to stop and when to resume them. This happened right in the middle of the pandemic. So we really changed a lot of how we were going to develop this very early on and went very much in this virtual kind of app world. And as we worked towards actually developing what this intervention would look like and this e-health tool, we came to realize some really important features around the need to kind of build this into existing health apps that existed in pharmacy spaces that we became aware of, and actually embed it into a community space. And we ended up deciding on community pharmacies. So we really started to identify, okay, we really need to develop a partnership with a pharmacy organization to make this work. And one member in our team, Ross Suzuki up in the University of Alberta, who is a pharmacist, was already doing work partnering with pharmacies and helped connect our team with Shoppers Drug Mart and Karen, and that's when we first met. And that's sort of what brought us to our initial meetings and conversations to really figure out how could we work together to actually deliver a trial and create some evidence in this space together. So I'm going to turn it over to Karen in a moment to really give her side of the story. But I remember just from my side thinking, okay, well, how am I going to approach this meeting? I mean, what are they going to think of this crazy group of people like trying to do this project? I mean, how are we going to convince them this is worthwhile partnering with us, and this project is going to be worthwhile? So I went into this meeting thinking, okay, I need to figure out why are we doing this? What are we trying to do, and convey this to this partnership? And well, I guess we'll see what happens from all of this and go from there. So I think we had some initial meetings over Zoom where we started talking. We had many, many meetings over Zoom talking about the problem, trying to convey the why, myself trying to get across the point why I thought this was important and worthwhile putting some investment and time into. So I'll turn it over to Karen to see how she felt after those initial conversations.
Thanks, Matt. Like I said, we're 2 years into this now, I think, since we had our initial conversations, and we're hoping that shortly we're going to get it to a big milestone of actually starting the build. So just to kind of give you a bit of the evolution, it started out as this is something that potentially, could be a paper-based initiative that then became, well, no, it needed to be some sort of app. And like Matt said, initially, I think it was this would be a standalone app, and then it was recognized, well, if we're going to get uptake on this, it needs to be integrated into something that's already a destination, because people aren't going to have 30 different apps and go to them just for specific uses. It needs to be part of a broader offering. So that was where Ross said, oh, I might know some people who have just such an app that this could potentially be integrated into. And that's the I word, right? Integration made it really, really infinitely complicated, which I'll get into further. But as we had our first discussions, because I am a pharmacist, I did see the value of this and the need for it and that gap in care that it would fill. However, I'm part of a bigger entity. So then I'm looking at how do I make this sellable internally to build the case so I can get the folks I need to work on this internally aligned with it. And I called that to Matt as kind of a, you're familiar with the Men Are From Mars, Women Are From Venus book. It's kind of what it was like a bit, right? Is, you know, we've got Matt over in Venus, I'm over in Mars, and trying to figure out how we bring this together to planet Earth. And so all that to say, over the past 2 years, we've managed to build the case internally for this as something that is, you know, valuable content as well as a tool for patients and pharmacists to be able to collaborate on, because we know pharmacists are, you know, engaged and integral in medication management, and this is a part of it for patients who have, you know, diabetes and need to be aware of what changes they have to make when they have illnesses. And we've navigated through our internal privacy, which is a really big behemoth, because if you've ever worked with a private sector partner, we're very risk averse, particularly in areas like privacy and security related to IT. So that was a huge piece we had to work through. Then the next piece was getting it on the priority list. I don't know if any of you are in IT, but IT is kind of like this black hole where things go into and you're not sure when they're going to come out or if they're going to come out or where they're going to end up in the queue. And so that's something we also had to navigate because we went back and forth a lot on, you know, do we integrate this sick day management app, or can we leave it as something that would be standalone for the first part, and then if it works, look to integrate it later, knowing that would be the path of least resistance. Matt and his team felt very strongly it needed to be integrated to make it usable so we could get a realistic perspective of, you know, is this thing going to work? So we pursued that route, but it wasn't easy. It hasn't been easy. I did actually just get word yesterday that it is on the queue, so the build is going to start relatively soon. But all that to say, as a partner with Matt, what I've been really appreciative of is the patience they've had with us, because we're not terribly agile when it comes to some of this stuff, and we don't have a long attention span, which is the other piece, right? We know in the research world, you know, you listen to Andrea and Braden talking about that being a 10-year initiative. We tend to try things for, you know, 5-6 months, and if it doesn't work, we pivot really quickly. So when I'm trying to tell folks this could be, you know, 3-4 years before we get a publication or the output from it, I really have to make sure we maintain their attention span to do so. And ironically, the folks you're going to hear from next, we've been engaged with them on that project in a slightly different role, and that one we have gotten to the finish, which I think is super cool. And I'm really looking forward to getting this one across the finish line. And I do want to say, I love working with you guys from U of C because you are very adaptable and flexible and really super patient with us, which is, I think, what has helped us to be successful and get us to the point we're at now. And I really look forward to how it works as we finish it and take this fully across the finish line.
Thanks, Karen. So it was a relief after our first few meetings that actually you didn't laugh at our ideas and throw us out the door. So it was very encouraging. But we had to figure a lot out, didn't we, along the way? I think as researchers, we often we're very regimented, and we really had to figure out the flexibility to work together. But you know, in the end, we actually identified there were a lot more opportunities that actually strengthened what we were doing than we had even conceived in the very beginning. We started to realize how this would be integrated into some of the additional scope of care and consultations that pharmacists were doing at Shoppers Drug Mart for diabetes care. The app itself to integrate was a huge strength to make this, you know, much more powerful in the end. If our trial shows it's effective, there's actually a way to really scale it up and integrate it into care. So it's opened up great opportunities. But like the messages we've heard, trying to understand each other's opportunity, perspectives and being flexible has been really important, and a lot of perseverance. I think these things can be very productive, but they do take a lot of time and hard work to get done. Thanks.
Yeah, great question. We were surprised as well. We'd spent many years planning and executing that study with the anticipation that it would show what we'd hoped, that people would take their drugs more and avoid downstream complications. When we look back at it, we've done some work, we've done some random forest analysis to basically see, is there anybody, if we splice this data every way possible using machine learning to find some group that benefits from this, we couldn't find any. We thought if we looked at the poorest of the poor, if we looked at the least health literate, if we looked at nobody benefited when we looked at it across all of these different strata. And interestingly, there is a signal that the people who maybe benefited were actually the least likely people in our minds. So the people who might have benefited the most were actually the people at the highest income. So everybody had incomes of less than 50,000. It was the kind of marginal people who were most likely to benefit. And we've got hypotheses and some qualitative data that bears out that people who are really at the low end of the income spectrum, saving these little bits of copayment aren't really enough to overcome the myriad of challenges they have. Whereas if they're people living on $50,000 a year and probably have many of their needs met, maybe this gets them over the hump and helps them afford their medication more. So ultimately, that's kind of what we think, is that this intervention was too small of an effect to actually result in changes to behavior that we were looking for. And also that the benefit program offered by Alberta Blue Cross is already fairly generous for this population. And so, as Braden talked about, we're hoping to go back to our original plan of studying people who are uninsured, not the seniors who already have kind of blanket coverage in this province, but there are many of the working poor, the working age folks who don't have insurance coverage, and that's who we're working with the government now to see what we can do in terms of, is there another trial here, or are there policy changes that need to be addressing those with the greatest needs?
Thank you very much. So many of you are working primary care with specialty practice, and particularly the first Alex, and so I'm just wondering if people want to comment on the restructuring, which will actually make it even more challenging for this incredible integration of specialist care with primary care.
I think already there, because I think with even simply being on different, we have Connect Care as a whole within that system, and then we have some of our other primary care systems have different electronic medical records. So even we really rely on something like Nectar, we're still sometimes limited. So we're still working on multiple different ways on how to communicate with each other. And I think with those kind of coming into different entities now, I think it's just going to probably amplify, in the beginning at least, probably some of those challenges for communication. I think especially with primary care to specialty. So there's lots of these pieces that can improve for the client's piece. Then for coming back to the healthcare piece, it can be challenging for that ongoing communication with care. So I anticipate that it will be challenging, but hopefully that we're moving in the right direction eventually.
Yeah, I can just build on that and give a concrete example that I was kind of alluding to, is that, as when I'm practicing within Alberta Health Services, I chart in Connect Care, and everybody else in Alberta Health Services can see my notes on my patients, but when I'm working at the Alex, Alberta Health Services has said I'm not allowed to use Connect Care, and so my colleagues don't necessarily know that this is a patient under my care when they come to hospital or Emerge or any other place. So there is this disjuncture created by the siloing that we have in our healthcare system, and it's probably only going to get worse as we separate primary care even more from the hospital services. So it's a great question, Lynn. I don't know the answer. I expect that it'll get worse before it gets better, unfortunately. Yes.
Just to build on that siloing, is there a possibility or way of researching or getting Connect Care to primary care physicians and primary care networks so everybody is on the same system? Is it my understanding now the system, if a family doctor's office wants to be in that they have to pay into that system? Does anybody know?
I think the right expertise for that question is in the room, but not on this panel. So I think Stephanie or Carrie or somebody, we have some tables in the next session for community-based primary care, and maybe some of the facilitators know the answer to that question.
Hi, so I do have some questions, more so for the Alex team, but it does kind of affect a lot of the things that you guys are working on. Because I work a lot within the nonprofit sector, so we're more specifically a resource center, so we do end up seeing like the symptoms or the consequences of a lot of the things that you guys are talking about. in terms of like navigating those benefits, affording their medications and things like that. So we do end up seeing a lot of people who have diabetes who end up at our services who, you know, can't afford their insulin or their medications or even like the foods that they need to be able to more adequately do their health. Is there any like resources or anything, especially for that Alex team who are going out into the community, who are doing these screenings, you know, informing people of what's going on medically for them, that you're able to then subsequently either refer out or have those supports for those individuals to then afford their healthcare after that?
Yeah, so our team does work with, we have clinics that we have social workers that will come and work with clients. So for those individuals, we do try and make sure that we're still doing that full level of care. So when we're doing the diabetes screening, we're still making sure that if they need medication or if they need kind of those referrals for those other pieces, that we are kind of connecting them. And that's that whole piece that we want to continue, where we're trying to support the whole person, and we'll connect them to social workers, or we'll connect them to supports to try and get that medication coverage, or we'll try and have some compassionate supply to get that, making sure that we can look at that whole person and making a plan for them. So in partnership with what the U of C was able to provide with that specialty service, we still very much acknowledge a lot of the clients that we serve have those barriers for getting medications or getting access to those sometimes other appointments that we're not able to do on the bus or in one of our clinics. So we still try and look at those areas.
Thanks so much for all the great presentations. I'm just wondering, building on the theme of sort of the dissolution of current approaches, would you say that partnerships create any kind of opportunity, if not immunity, but by looking to other sectors that have different types of influences? I won't use the word stability for anyone in our climate these days, but what do you see that offers from both sides of the table?
I think sometimes you can get paralyzed by things happening around you, and it's certainly nice to have partners to work together. I think it does give you more confidence to move forward. You don't feel as isolated, and I think it does open up opportunities. So I'm become a big proponent of just kind of trudging on despite everything else that's going on, and trying not to worry about all the noise sometimes, and move forward with things that you still feel are important. And I think, you know, there's always going to be challenges and changes going around us, but I think some of the partnerships can help you work together and open up more opportunities that you probably are not going to get just working in isolation. Which is well.
First, Karen? Sure.
To be honest with you, no, there wasn't really anything that I didn't expect, other than how incredibly patient they were with us, because we had a lot of hiccups, and Matt can attest to that, and Reed can attest to that as well. So there was a lot of learnings on our side in how to manage this, because I mean, the one thing I'll speak to, you know, with Reed's initiative was everything we had to do manually, and because it was outside of our standardized processes, which made it really difficult. But they stuck with us, and we did it. And like I said, similarly with the initiative with Matt, it's outside of our standardized processes. And so I think I wasn't surprised at working with them. I pretty much knew what to expect. I don't know that they knew what to expect from us and how challenging we were going to be. Because you kind of, I think, have this perception, you know, it's private sector, so things run smooth as silk, and they're this well-oiled machine. Not really so all the time, right? We're really complicated, and we can be really bureaucratic. And like I said, we're not terribly agile in a lot of things, particularly when we have, you know, projects like this, which I would call unicorns a bit, that deviate from our processes. I don't know.
Yeah, I can just add, I don't think there was anything that was surprising, other than there was lots of support from the U of C. And again, I think just there's a lot of patience, like we talked about, in kind of how our nonprofit world works and kind of a lot of the things that we have in some of our core services. And even though we had very similar goals for clients, there was lots of workflows that were very different, and kind of what we needed to do in the and build kind of in our sector, in our organization, that maybe wasn't already built, that maybe was built in some of the bigger organizations or things like that. So building in the research aspect was a learning curve for both, and I think just the patience and the support from the university was very helpful to make that happen.
Just a quick one, yeah. I was interested in what Karen was saying, well, a couple of you were saying about timelines. It made me think of that thing in Ghostbusters when Ray gets kicked out of the university. He's like, I've worked in the private sector, Peter, they expect results. And I was just wondering, like, what the compromise was there. Like, was it kind of like shoppers being like, well, I guess we have to work at the pace of research, or the other way, or if you worked that out between you?
Boy, yeah, so I mean, certainly it does create friction, a lot of friction for me personally, because I'm the one that kind of has to navigate that and bridge that internally, but that's my job, right? In the role that I am, you know, I have responsibility for our partnerships, so I need to be able to bridge that and manage expectations on my side, and that's where I think, you know, working with the university, I need as much information as they can give me so that I can manage those expectations. Because, like, literally, I'm not exaggerating. I would communicate internally that a grant was approved, and they would be like, oh, so we're going to have a peer-reviewed article in 6 months? And I'm like, absolutely we will, for sure. But unfortunately, that's the reality, right, of the gap that exists between, you know, timelines and expectations. So, like I said, partners, give me the information, and then I can manage the expectations. I don't know if you guys have any comments on
I just
that?
say my reflection on that is that there's some things that I think community partners do slower than us, and there's other things that we do slower than them. And the unfortunate reality is I think everything just goes way slower. So sometimes you guys turn stuff around and get it to us, and then it sits in legal for a year or 18 months, and then it gets back to you, and it sits in your desk for a while. So yeah, I think just planning that things are going to take a lot longer than you might anticipate, I think is the way to go.
Thanks, everybody. I think now we are going to ask you to get up and move to your tables for our next session on building meaningful relationships, guided table talks and partnerships matchmaking, and I will invite Tessa to come up to moderate that session.
All right, everybody, welcome back after lunch. Hopefully you are all able to get some food. If you're still eating, that's no problem at all. Please feel free to finish up. It's my pleasure now to introduce our keynote presenter for the afternoon session of today's meeting. I'm pleased to introduce Dr. Stephen Wong, who is the director of St. Michael's Hospital's MAP Center for Urban Health Solutions, and also a professor of medicine at the University of Toronto. Stephen's research focuses on interventions to end chronic homelessness and to improve the health of people experiencing homelessness. He holds a Tier 1 Canada Research Chair in Homelessness, Housing and Health, and on a personal note, Stephen was actually my supervisor for my postdoctoral fellowship in Toronto and has been a mentor of mine for many years and is a world-renowned expert in the field of health and homelessness. And we're really pleased to have him here today, and he's going to be speaking largely about how we can work together, kind of the theme of the day, how we as academic and community partners can work together to do good things and to improve the health of our communities. And Stephen's, both in his own research program and in the programs of those in his center, have been doing this type of work for many, many years, and really an example for us of what we'd like to become at the University of Calgary in terms of a nimble group of researchers who are able to work with community partners. You've heard some examples of those today, but we'd love to do more of it, and that's why we've asked Stephen here to tell us about what his center is doing well and how we can emulate. So please join me in welcoming Stephen to the stage.
So, good afternoon, everyone. Let me just see. Okay, there we go. So, I'm going to be talking to you about mapping a path to research and policy impact in health equity. First, let me start by telling you a little bit about the center that I'm the director of, MAP, also known as the Center for Urban Health Solutions. So we are Canada's largest research center focused on health equity and the social determinants of health. And if you want to learn more about us, you can go to our website at maphealth.ca. We are made up of about 35 scientists and investigators, about 150 research staff. We're based at St. Michael's Hospital, and we're fully affiliated with the University of Toronto. So I'll start by saying that the first question people usually ask me is, what does MAP stand for? And my response is that actually MAP doesn't stand for anything. It's not an acronym or an abbreviation. It actually is a name that we chose to convey the fact that we are mapping the path or charting the path to a healthier future for everyone, to greater health equity. So I realized that, and I'm going to tell you a little bit about MAP and tell you actually a bit of our history and some stories of the work we've done. But I also reflected on the fact that charting a path or mapping a path is perhaps a misnomer or an improper analogy, because it implies that if you just follow the directions and follow the steps, you'll get to your destination. And in fact, that's not the way MAP developed. It's not the way that you or your programs will develop. And so I'm going to tell you not the path to get to where you want to go, but some stories from our experience and how there are some key factors there that could contribute to your success in the future. I might add that as I tell these stories, I'm always mindful of the fact that we probably all know a family member or friend who tells stories, and at the end of the story, we're kind of going like, what was the point of telling that story? So what I'm going to do is tell you a number of stories, but each story actually has been carefully selected to demonstrate a point, which I will make clear in the process of my talk. But I also want to promise you that every story, although carefully curated, is 100% true. So let me tell you more about MAP. MAP is home to a number of outstanding research scientists. We actually have 9 Canada research chairs at MAP. We have a number of, we have 6 research pillars or themes that you can think about our areas of research strength. Early life interventions for children and youth, equitable access to healthcare, homelessness and housing, which is my area of focus, substance use and drug policy, violence prevention and response, and sexually transmitted and blood-borne infections, or STBBI. Now, this is a diagram, and I'm not going to, you don't have to be able to read it. It's more just a reminder for me to just talk about how we think about the work that we do. And really, it just indicates in 3 stages, similar to what you've seen in earlier presentations, how we think about the work we do. We start with data, conducting studies, collecting data, working at the local level, but we always from the very beginning, we're thinking about what is the next stage? How will we be able to scale up the intervention if it's proven to be effective? And then, very importantly, in the focus of this conversation, how do you translate those findings into programs and policies that can affect a larger population? So now I'm going to tell you a few examples of work that researchers at MAP have done across these 6 pillars of research. So the first is about addressing food insecurity in schools. So this is Dr. Katerina Maximova, who actually came to us from the University of Alberta. And her focus is on school-based interventions for young people, building upon the Apple Schools model, which was actually developed here in Alberta. And she does this work in close collaboration with school districts. This is a theme throughout our research and the theme of this event, which is the need to collaborate with not just community organizations, but with people with lived experience and lived expertise of the challenges that we're seeking to address and who are working with us to achieve greater health equity. So Dr. Maximova's work in collaboration with school district boards focuses on improving healthy eating and teaching about nutrition, greater physical activity, and mental health. And she's done this work for many years and has successfully implemented it in many different school districts in many different provinces. And very importantly, this work has also been tied to her advising the federal government on a school nutrition strategy, which was recently implemented and which she was an advisor to. So again, illustrating the fact that we're linking research to policy and policymakers. This next example is actually really quite related to the study that Dr. Manns described earlier. So you're all probably familiar with the fight to create pharmacare, or the work to create pharmacare in Canada. So MAP has had a role in this effort that's really involved a whole host of people over the years. This is Dr. Nav Persaud. He's a family physician, and he spearheaded the Clean Med study, which was a randomized controlled trial of providing essential medications for free to people who were in primary care practices, patients in primary care practices who were having difficulty making ends meet and affording their medications. And so he developed this very audacious study where people were enrolled and then randomized to either receive the medications their doctors were prescribing at no cost or usual care. And he followed them over 2 years. And the slide shows the PLOS Medicine paper that demonstrated that not only did this, not surprisingly, increase adherence to medication, but it also resulted, interestingly, in cost savings when you looked at administrative data, because people ended up going to the hospital less often. And I guess one point, I guess, since it's kind of related to the study that we heard about earlier, is that this actually aimed at the working poor. These are people who were not eligible for welfare or disability and therefore did not have access to drug benefits, but they also didn't have the kind of jobs that provide a health insurance plan with drug coverage. So these were nannies and Uber delivery people and waiters, people who were quite likely making the decision not to take their medications because they had to pay the rent or buy food. So interestingly, this work was part of really an overall coordinated campaign to try to create a pharmacare program in Canada. And you're probably aware of that this was involved a number of advocates, scientists, and politicians. The slide actually shows a story about how ultimately, as you're aware, there was an agreement made and a Pharmacare Act passed, which now is hopefully over time going to allow at least the provision of medications for diabetes and contraceptive pills to everyone who needs them across Canada. I guess one interesting side point is that I noticed as I was preparing my slides that the news story includes the photograph of 2 politicians who I will not name, but I think you're all aware that in the years since this came to pass, they've both left the scene politically. And interestingly, I think it illustrates the point that you have to work with the political parties that are currently in power, but that to realize that no politician and no political situation lasts forever, and we have to think in the longer term than just the latest political cycle. And so Dr. Perceau is now on the federal government's expert committee to advise on the ongoing work of creating a national pharmacare program. So my next example involves Dr. Tara Kiran, who's also a family physician at MAP and a research scientist. So she created the Our Care program, which is the largest effort to consult with people across Canada on how we need to reform and rethink our primary care system. And so she came up with this quite audacious, again, plan to do a consultation across Canada. It involved almost 10,000 people virtually and through online polls. And then she convened 6 provincial panels where people met in person. So a selected group of the public met in person to discuss what needed to be done for primary care in their province. And this was done with the very specific goal of getting out of the box of doing it just in your own province, so that everyone in every other province and territory said, well, that's nice, but what about us? So this really aimed to get around this. And after these consultations, and I just want to show the next slide, because it shows photographs of people who participated in these panels across the country, the importance of involving people, involving the community, of going to the grassroots and not doing it from in a top-down approach, but involving people from the very beginning, who better to advise us about what primary care needs to look like than everyday Canadians who struggle every day to access primary care or get the primary care that they need. So again, I call this effort audacious because when Dr. Kiran first told me about this, I thought, well, this is great, but is it really going to result in any change? Maybe not. It seems like it's really likely to not result in meaningful change. And so the next slide is just an amazing demonstration of this, and I know you probably can't read it, but so I'll explain to you what happened. The Our Care consultations resulted in 6 basic recommendations about what the principles of primary care should look like. And just for example, one of them is that essentially that everyone should be able to have access to primary care based on their geography, so that that if you lived in a certain area, that there would be primary care available to you in that area. Just like if you move into a neighborhood, your children can register for a school and no one can tell you, I'm sorry, there are no schools available in your neighborhood. Your children can't go to school. You can't do that. So one of the recommendations was that primary care should work the same way. And so they came up with these 6 recommendations, and I won't read them here for you, but the amazing thing is just a few weeks ago, the government of Ontario passed the Primary Care Act, which essentially established 6 principles for how the government of Ontario is going to improve primary care. And essentially what they did was they took the 6 Our Care principles and just kind of reworded them a little bit and incorporated them into the act. Now, obviously, an act without any there's going to need to be a lot of implementation and a lot of ongoing effort to turn these principles into reality. But I think it's amazing that the work that Dr. Kiran did at MAP has literally been translated into almost word for word a provincial act that is going to govern how things move forward. So again, a great example of having impact. And so this example is in the area of substance use. Dr. Ahmed Bayoumi and Dr. Dan Werb are experts in substance use and drug policy. And so they were co-authors on a study published in The Lancet, which examined the impact of supervised consumption sites on the risk of overdose deaths in the communities around those supervised consumption sites. And the unique feature of their study was that they used a geographic approach. So they were able to geocode the location of overdoses and assess the impact of a supervised consumption site on the assumption of modeling that the impact would decrease as you got further away from the supervised consumption site. So you would expect a greatest reduction close to the supervised consumption site and less so as you move further away. And indeed, this study demonstrated that effect. So I use this example because it's like resulted in a very high impact publication in a very high impact journal. I guess it's also, unfortunately, an illustration of the fact that research does not always translate nicely into policy. And as you're probably aware, the government of Ontario actually changed the law that actually ended up closing many supervised consumption sites and obviously ignoring evidence that they don't cause harm and in fact result in many benefits. So the next example, these are actually vials of vaccine originally intended for smallpox, but actually it is also used to prevent Mpox, the disease that there was an outbreak of recently, spread very rapidly across many different countries. So this slide shows Dr. Sharmistha Mishra, Dr. Daryl Tan, and Dr. Ann Burchell, who collectively focused on sexually transmitted and bloodborne infections. And so they did the first ever study of the use of the Mpox vaccine, the use of this vaccine, which was originally for smallpox, to prevent Mpox. And their study showed that there would be there was an enormous benefit even with one single dose. This slide just illustrates some of my work done in the area of homelessness, showing that research that we did on the effect on risk of hypothermia among people experiencing homelessness was occurred at relatively milder temperatures, and which led to the city of Toronto changing the threshold at which it opens warming centers for people. So I'm going to now do a little bit of discussion. So I have 10 minutes left, and I'm going to talk about how this all got started, because I've kind of given you kind of recent examples of what MAP has accomplished as we are. But I think the question is, how did we get here? And so I'm going to tell a couple of stories which I think will help illustrate some key points. So I'm going to start back in 1892 when St. Michael's Hospital was founded by the Sisters of St. Joseph's to care for the sick and the poor of Toronto's inner city. So the reason I raise this is that from the beginning, our institution has been initially focused on serving those who are disadvantaged, but then that grew to include a focus on the importance of seeking justice and equity and of the social determinants of health. So that's embedded in who in our institution's mission and values, and that affects who we are as members of that institution. And so I think that that was really a fundamental part of how MAP came to be. So back in 1996, St. Michael's Hospital hired its first researcher in population health. That actually was me. And so that was really the beginning. So really, literally at that time, no one at the hospital had ever done any research on anything other than traditional medical topics or lab medicine. So that gives you a sense of how far we've come in about 30 years. So in 1998, what was then called the Inner City Health Research Unit was founded with a group of 4 core scientists. And then in 2001, we got core funding from the provincial government. And the reason I'm mentioning this is that this really illustrates the importance of institutional commitment and support. Because what happened was that the hospital, through arrangements that I won't get into, the province agreed to fund research at the hospital. And the CEO of the hospital, recognizing the mission and values of the hospital, said, we're going to use this money to support what was going to become MAP, because it's so central to who we are and who we want to be. And so that funding is what allowed MAP to grow tremendously and to recruit many new scientists. So I'm going to fast forward to 2004, when Dr. Pat Ocampo became our director, and we recruited her from Johns Hopkins to become our director. I think that the two key things here that I want to point out is that, first of all, it's so important to recruit top talent. Outstanding, not just outstanding scientists, but outstanding staff, and to retain and keep and support and build up those staff, because that really is the building blocks of a successful center. The other thing is the importance of leadership. Dr. Ocampo set a wonderful example of what I would consider like 3 principles that are needed for success in this area. One is absolute dedication to their leadership role. Secondly, a focus on developing others. So it's not about building up the leader as this figure, but to build up the whole team. And third, and especially, and a sense of servant leadership, that you're there as a leader to serve the people in your center, not to tell them what to do. And then I would just indicate that the key things that we did is we focused on community-partnered research. So that's always been in our DNA, and it's been something that we have really tried to do throughout. It's hard work, as has been, I think, illustrated by many of the discussions here, but it's so important. What I would mention is that rather than having one kind of strategy, our center has many different groups that engage with our scientists. So there's a group that engages with Dr. Persaud on affording affordable medications. There's another group of people who use drugs to work with Dr. Bayumi and Dr. Werb. So, and there's a group that works with me that have lived expertise with homelessness. So we've done it by topic area or by area of focus. Throughout this time, there was a growing emphasis on intervention-focused research. And I guess that I would just point out that one key aspect that I think is an advantage for us as a hospital and is that as a hospital, we understand the importance of clinical interventions in the healthcare system, but we also understand that the social determinants of health are really what are driving illness in the population, and that it's not an either-or proposition, that we can, as a hospital, kind of bring those two together, and rather than saying, oh, it's all about healthcare or it's all about the social determinants of health, we can say it's about bringing both together. During this time, we had a CHR-funded postdoctoral fellowship, which trained future researchers, many of whom have gone on to really successful careers of their own. Again, the importance of training and supporting and mentoring the next generation of researchers in this area. So then I'm going to actually talk to you about a crisis and the opportunities that arose as a result of that crisis. So I mentioned that we received provincial core funding for our research center. So in 2013, the province basically cut that funding, and we were left essentially on a limb with a kind of a one-year expiration date. And so what we did is we transitioned to a model of philanthropic funding with the strong support of our hospital's foundation and with some dedicated lead donors who really saw the value of our vision and our work. And so I have to admit, as director of MAP, I've spent much of the last 10 years as a fundraiser. But I guess what I would just point out is that it's a wonderful, actually it's a key aspect of our success, the ability to fundraise significant amount of donor dollars together with our scientists' ability to get research funding from peer-reviewed grants really, again, comes together and is a force multiplier for our work. And just as a specific example of that, Dr. Persaud's work was made possible by a $1 million donation from a donor, which allowed him to provide the medications for the patients. And the research funding came from a separate peer-reviewed source. in 2019, you might ask, well, like, why are you called MAP? So in 2019, we changed our branding and started calling ourselves MAP. And that was at the advice of some of our donors and leaders who said, basically, you need to create an identity and a brand that actually is easier for someone who's not in research to grasp. And so we took that advice, and so that's why we now talk about MAP as, and it takes us out of that kind of academic, the Center for X, Y, and Z kind of model of presenting oneself. So we've increased our emphasis on communications, and this again is a key point. We spent a lot of time and energy on, and we have staff who have expertise in packaging up our accomplishments and then spreading the word. And that is incredibly important. It's a skill that, we may think we have, but we need help doing it as scientists. And in fact, we could all use that help. And I just want to point out that the slides that I showed you, many of them are not ones that I made, but they were made by our communications person to convey the importance of the work that we've done. And then lastly, I just want to mention that we have, as a part of our philanthropic kind of drive, we have established a partnership, a transformative partnership with Staples Canada, which had launched a fundraising campaign with MAP, and it's called Even the Odds. The idea is that it's focused on conveying to people who come into a Staples store in cities and towns across Canada why care about health equity and marginalized populations and what can be done about it. And so it's been an incredible privilege to have this partnership. It's not only expanded our ability to do our work, but it's really, I think, enabled us to communicate to a broader audience and also raise our sights and think not just locally or provincially, but nationally. So that's, I'm just going to show you, that's the Even the Odds branding for the campaign. So if you ever go to Staples Canada, a Staples store, just look for this. Actually, that is MAP's collaboration with Staples. So I am going to just, I know I'm going to go a little bit over now, but I am going to say a few words about translating research into evidence. So this is just some thoughts that I wanted to share. I think we often think about, and this is stuff that you probably all know, but I just want to say it out loud. So evidence, we have this idea of evidence-based policymaking, or maybe the more naive among us do, that this orderly, rational process where we'll identify a problem, gather evidence, and lead to logical decision-making, and that researchers should really be encouraged to improve how they communicate their findings so that they can contribute to this orderly, rational process. But we actually all know that that's not the way things happen. And so the way I think about it and the way I think MAP researchers think about it is we're policy entrepreneurs. So the idea is that we need to be able to tell a persuasive story, a true story, to frame a policy problem and reduce ambiguity. So you can't get into all the complexities and the detailed analyses. You have to have a simple story that you have to combine evidence with emotion, and you need to leverage policymakers' pre-existing beliefs and biases. And you have to have a solution ready in advance to chase the problem when it arises. So you can't see a problem arise and then try to solve it. You have to be ready with the solution when the opportunity arises to address a problem that suddenly comes to the forefront. And these are windows of opportunity that we need to exploit when policymakers suddenly need an answer, and they're going to reach for an answer, and our goal is to help them reach for a good answer as opposed to a bad answer. So what does this mean? It means we need to build our public credibility as trusted experts, and that's perhaps our greatest asset. We need to we need to make a long-term investment in developing alliances with all of our partners in the community, people with lived experience, other researchers, et cetera, we need to build these networks and increase our knowledge of the system and connect with people who have the inside scoop. And what I tell people, at least in my experience, is that often there are people who understand how policy is getting made, and we have no idea. And it takes someone on the inside to say, and I'll just give an example, okay, so city council, everyone's already made up their mind. There's only 2 people who are wavering. And so it doesn't really matter who you talk to except for these 2 people. And they'll only listen to people who live in their area of the city that they represent. So you need to find, that's how you need to approach this. That's a real example. And then the last thing is that just, again, even with your best efforts, policy impact is not assured, as I think we're all aware, and it's really hard to achieve. This is a really difficult thing to do. So this slide just summarizes what I've tried to kind of illustrate in terms of key factors contributing to success: your mission and values, your institution's commitment and support, your ability to recruit and sustain top talent, I didn't mention it, but your diversity. I would say that the fact that MAP spans a whole range of research areas, disciplines, and approaches is a strength. Your leadership, your range of interventions are important. And again, we need to focus on impact from the very start of when we're planning our research program and our partnerships. I've already mentioned the critical role of community partnerships, and then, of course, the role that fundraising and communications can play. So I hope that this has been helpful. It's not a roadmap. It's more a series of tips and suggestions that looking back, I think have been key aspects of helping us get to where we are today. Thank you very much.
Have a couple minutes for questions, if there are any questions for Stephen.
Very much for your thank you very much for your presentation. My question concerns this very interesting collaboration between MAPS and Staples, and maybe you could elaborate a bit on what it is, because I tried to Google it just now, and there's no information at all. So I wonder what's the prehistory of it, what's it about, and is it kind of an advertising campaign, or is it more related to the core values and mission of the project, or what's it about?
So yeah, it's actually, if you go to the Staples website and look, you might be able to find even the odds. It's not primarily like an online thing, it's mostly store-based. So, but the concept is that we wanted to create a campaign together that allowed for awareness raising about health equity and the importance of that in communities across Canada, and then to fundraising for MAP's work, which then puts the onus on us to think about how can the work we do benefit everyone across Canada, right? As opposed to just people in Toronto. Because just to be honest, if you're going into a Staples store in Saskatchewan, you want to know how can we help people in your community in Saskatchewan. So I think that's kind of the idea behind it. So people they do fundraising in the store and corporately for us. I guess that the really key thing, I don't know if that answers your question, but the key thing is that the goal is to think about how does the work we do how can it potentially help everyone, and to think more than just locally about our work. Down there?
So just to build sort of off of that point, you talked about, trying to fit your work to work for everyone, presenting your work as something that can work for everybody. But something I wanted to ask was about the question on partisanship and political will. You touched a little bit on it, how you kind of have to find those time frames. Policymakers are able to or willing to make a change, How do you navigate that as an academic, as a a change maker to find those points and exploit them, or exploit them?
It's a great question. So I guess my first point is that you have to have incredible persistence. And because you have to think about the long game here. This is not about what can I do in the next year or even 5 years. I mean, I've been doing this for 30 years. So you have to think how are we going to have an effect in the long term. The other thing is to realize that you can make a case. I mean, health equity is sometimes viewed as a left kind of priority, but I guess that what we try to do is make the point, first of all, that health equity is really about making sure that everyone is thriving in your community and giving everyone a fair chance to benefit from the wonderful things that Canada has to offer for people, right? So I think that that's the way we frame it, not as, a political left-right spectrum. And I guess there's actually research evidence to support the fact that in more equitable societies, everyone does better. So then the other point is that I would say that we have tried to work with all political parties and to realize, so for example, yes, pharmacare was the result of the Liberals and the NDP having kind of a temporary marriage of convenience, right? But the Our Care work resulted in the Primary Care Act in Ontario under a conservative government. And I think that reflects the fact that we don't frame primary care as a left-right issue. It's an issue that affects everyone, and therefore, it's a problem that any government wants to be seen as doing something about. So that's, again, a way that we can achieve a win in a place where you wouldn't say, for sure they're going to be like our friends. So I just think that we need to avoid pigeonholing ourselves, and I guess one of the things that I would say is that one of the things we bring as researchers that is of benefit is the fact that we're providing, I wouldn't say objective evidence, we're providing a balanced, reasoned approach to the issues. And we're telling people, if you do this, this is what's likely going to happen based on the evidence. We're not taking really hard positions that then get us labeled as advocates, which is often, means that your credibility is being denigrated. So I think that that's one thing we have to be aware of is the need to protect our credibility.
So we'll move on to our next series of kind of rapid-fire presentations. The title of this next session is Understanding Processes, Overcoming Roadblocks, Practical Considerations for Pragmatic Trials. Our first presenters will be from the Health Policy Trials Unit. Terry Saunders-Smith is the manager of the Health Policy Trials Unit and has 16 years of experience coordinating industry and investigator-sponsored research projects. And she's been working on health policy trials for the last 7 years, including many of the trials you heard about this morning. And she'll be co-presenting with Tegan Moth, who is a research coordinator with the Health Policy Trials Unit, who has been also managing and coordinating several of the trials, including the FoodRx trial that you heard about this morning. So Terry and Tegan, if you would come on up.
Good afternoon, everyone. So the Health Policy Trials Unit, or the HPTU, is housed within the O'Brien Institute for Public Health at the University of Calgary. It is co-directed by Dr. David Campbell and Dr. Emily Quinn, and we have a growing team of trial coordinators, research assistants, postdocs, and faculty collaborators. We are one of 11 clinical trial units that are funded by ACT Canada, which is an initiative to improve clinical trials across the country. Our work focuses on strengthening the design and implementation of pragmatic health policy trials, and we work across academic, community, and government sectors. Today, we're going to talk about some of the challenges when planning a pragmatic health policy trial, including challenges with funding applications, relationship development, intervention design and delivery, data collection and analysis, and ethics and compliance. Securing funding for any research project can be tough, but this is especially true with pragmatic policy trials. Funding agencies tend to favor a more traditional randomized control trial and may be less receptive to more adaptive or real-world designs. Even more, community organizations that want to take part in policy research may not have the experience writing randomized control trial related grant proposals, and this process can seem very overwhelming. Another common pitfall is underestimating the budget. There are many hidden costs within a pragmatic trial, such as relationship building, stakeholder engagement, knowledge translation, and all of these costs are difficult to put on a line item in a budget, but they're crucial for the project's success. Strong relationships are the foundation to a successful and impactful policy trial, but relationships take time to create and build. In a grant-driven environment, time is a luxury. We often need relationships at the grant writing time point, but without funding in place, relationship building usually is not the priority. Furthermore, policy trials are strongest when they're co-created with input from all sectors. However, academics, policymakers, the community, we all speak different languages, we have different priorities and different timelines. So this can be very difficult to manage. There's not usually a neutral broker that can align the priorities and balance the power dynamics that exist.
There are several challenges that you may encounter when designing a research intervention and its delivery. It can be difficult to balance scientific rigor with the feasibility of building an intervention into an existing system. Community organizations hold the deep knowledge of what is most needed and what can be done, however, may not have the experience to translate these ideas into a testable intervention. The structure of organizations and the resources available make implementing an intervention seem daunting and challenging, but the synergy between researchers and community organizations means that we can help overcome these challenges, find a solution, and implement trials efficiently and effectively. Later in the session, we will have Becky Wong, who will expand further on embedding trials in Connect Care specifically. Ensuring community benefit while protecting participants' rights and privacy takes careful planning and ongoing monitoring. The intervention design and delivery play a key role in determining the types of ethics review that is needed. There may be projects where institutional review by a research ethics board is not required, but internal organizational approval and ethics is required, and vice versa. Waivers of consent, alterations to consent, and debriefing are nuanced and complex to navigate, and piecing these processes together can be daunting. However, organizations and researchers coming together and sharing their depth and breadth of experience means that, again, together, the interventions can be more efficient, more effective, and more smoothly implemented. Fortunately, we have Stacey Page as well here to present more on this later this afternoon. There we go, sorry. Data collection and analysis challenges are also rooted in the intervention design and delivery. When working with real-world data, it takes careful planning to access relevant databases, to produce and develop tools that produce the most complete and consistent data. There may be differences in what is meant by meaningful data, as well as the generalizability of the findings. Jesslyn Holodinsky will be touching on the data collection and analysis later as well. So this is where the HPTU comes in and how we can help overcome these challenges. So we offer services in 4 domains, including science coaching, operations and research coaching, analytics support, and partner brokering. Science coaching includes help with project conceptualization and design, including protocol development and guidance. We can turn those local ideas into testable interventions and co-develop grants to increase funding opportunities. Operational and research coaching includes research training for staff in an organization to increase the capacity within an organization, as well as staffing and material resources to streamline trial implementation. The analytics support comes from our dynamic HPTU team, which includes research analysts and associates that can help with calculating sample size, reducing biases such as spillover effect, and outcomes analysis. Partner brokering means that we can leverage the HPTU's extensive knowledge and expertise to connect academics and policymakers. Together, ultimately, we want to expand our focus to include more community organizations in the future, as well as government and health system projects. Together, we can co-create evidence to inform policy to create systems change together. If you are a researcher, an academic, or a community organization that's interested in learning more about this, there's our email, as well as if you scan the QR code, it's just a brief contact form to fill out if you would like us to contact you about your future research. Thank you.
Excellent. As Terry and Tegan foreshadowed our next speakers, I believe next up we have Stacey Page, who is an associate professor in the Department of Community Health Sciences at the University of Calgary, and she is also the chair of the Conjoint Health Research Ethics Board and a member of the Research Ethics Boards at MRU and AUA. Dr. Page has served on Canadian Bioethics Society and the Canadian Association of Research Ethics Boards, and we're very pleased to have her here to speak about considerations from an ethics perspective for pragmatic trials. Thanks, Stacey.
Hi, thanks for the introduction. Thanks for having ethics on your agenda today. I have 8 minutes to impart a lot of wisdom to you. So away we go. The green arrow. All right. So research ethics is about how people are treated. No matter what your research is about or what your design is, policy requirements are grounded in the same 3 core principles. These are respect for persons, concern for their welfare, and justice. Respect for persons is about respecting choice, and we usually see this operationalized through informed consent. Welfare is about broad quality of life considerations and how people might be affected by research, physically, mentally, economically, socially, spiritually, culturally, all these things. Justice is about fairness and equity, with nobody in research being unfairly burdened or excluded. The intent of research ethics review is the protection of individual people, balanced with consideration of public interests. Research ethics considerations should be made through the eyes of prospective participants. So what do the people you are engaging with feel about your research undertaking? How do they feel it? How do they experience it? There's a variety of regulations that impact on research conduct. These are the TCPS, the Health Information Act, Health Canada regulations, as well as myriad institutional policies and organizational policies and procedures. Okay, so pragmatic policy studies sometimes reflect QA/QI intent, as we heard in the previous speakers. The distinction between QA/QI and research can be blurry. If there's any ambiguity in what your project's mandate is, it's best to have the intent clarified up front so that appropriate oversight is sought. The CHREB encourages this kind of consultation up front. We ask project leads to provide a brief description of what they wish to undertake, their RECI score, a brief rationale for why they believe the project is QA/QI, as well as a letter of support from the relevant impacted clinical area indicating that they too believe it's QA/QI. Based on that, we come to a determination on what the best description of the primary intent might be. When projects are best considered research, they should be submitted for review. When they're QA/QI, we give a formal exemption letter that project leads can use at the time of publication or as needed. And it is not the case that Research Ethics Board approval is needed for publication. So Chapter 11 of the TCPS provides guidance for the conduct of clinical trials. There is a number of concepts related to trials generally. It doesn't use the term pragmatic anywhere in the document, but it does give some consideration to cluster randomized trial designs and registry studies, which are sometimes used in pragmatic trials. So generally, trials must be informed by background evidence and systematic reviews. Trials shouldn't be conducted on questions that have already been answered, and they should be started from a position of equipoise. Many trials are conducted by clinician researchers who have a duty of care, an obligation to act in patients' best interests. They need to clearly communicate to participants what the purpose of the study is, that it's to evaluate something, and they need to explain how the study might impact patient care or use of patient information. Typically, assignment to study arms is prospective. It may be randomized or not. It may take place at different study stages, and participants may include both providers and patients. In cluster randomized trials, assignment might be by groups like clinics or hospitals. Registry studies pull on clinical data, and these study design elements impact on recruitment and consent. So ideally, consent takes place prospectively and comes from the participant. For some studies, this might not be possible. Consent can be obtained from a surrogate, obtained at some point after enrollment, or not obtained at all. So both the TCPS and the Health Information Act permit researchers to request and justify use of these alternatives. The stronger the argument that researchers provide aligns with policy criteria, the easier time we as the REB have in considering the alteration. TCPS permits alterations for minimal risk research, where the research won't impact participant welfare, where a consent requirement would make it impossible to conduct the research, and where debriefing has been considered and will either be undertaken with people or where a reason for why it can't be undertaken is provided. Debriefing should be undertaken where possible, and this involves telling people that they have been involved in research, explaining why their consent wasn't sought up front, and giving them the opportunity to withdraw their data at their choice. Research in emergency situations is another instance where prospective consent can be waived. People are enrolled without consent, and consent for ongoing participation can be sought for them or a surrogate as soon as possible after the fact. Some research questions can be addressed by using clinical data. Becky's going to speak about this in a bit. The Health Information Act permits researchers to request information without consent if they're able to demonstrate the importance of their research question and obtaining consent isn't practical, feasible, or reasonable. Then we're already at the recap. So be clear on your intent, know what the rules are and where to find them. Be mindful of how people might perceive what you're doing and how the core principles apply to them in your research. There's flexibility in the consent approach. The onus is on you to justify the alternatives you wish to use in your given research undertaking. And the REB is always available to talk about this. We have an interest in helping you put your best foot forward and really try to take a collaborative approach to problem solving and getting things launched. Thank you.
Our final presentation in this session will be by Dr. Jesselyn Holodinsky, who blends the worlds of emergency medicine and data science in her role as an assistant professor at the University of Calgary. She tackles complex health challenges, transforming data into care pathways and better outcomes for patients in crisis in the emergency departments. She's also Director of Artificial Intelligence and Data Education and Ethics in the Cummings School of Medicine, championing responsible AI integration. She also works at the Center for Health Informatics in the O'Brien Institute for Public Health at the University of Calgary, and she's going to speak to us about accessing data and how, as we think about pragmatic trials, we could plan to access routinely collected data sources. Jesslyn.
Thanks so much, Dave, for the intro and for having me here today. So this is great to come right after Becky's talk, because I'm going to talk about non-EMR data, so data that is collected for routine administrative purposes and why you might want to leverage some of that in your pragmatic trial. And I'm going to, if you are not familiar, I'm going to introduce you to the Center for Health Informatics, because we have a great unit of people that can help you with accessing data that is collected for administrative purposes. The CHI has been around since 2019, really with a goal of furthering precision medicine and precision health through facilitating timely data access. So we are a really fun hub where we have both university researchers and analysts and also Alberta Health Services researchers and analysts working together. We have analysts embedded behind AHS firewalls such that you can access data that might not be able to be released out of those firewalls. So it's a really unique place to be. Thinking about why you might want to work through a pragmatic trial in Alberta, as I'll call this the Alberta Data Advantage. So given our integrated health system, we have a ton of data available to you. Now, you've just heard some about EMR data, but thinking about some of our non-EMR data assets, and you might not be able to read them all on this slide, but things like, NACRS, so talking about administrative data that's collected in the emergency department, the discharge abstract database, so administrative data that's collected from hospital stays, thinking about things like the pharmacy information network, so prescription medicine dispensations that happen in the community. These are all data sets that we can help you access at the Center for Health Informatics, so that you might think about using some of those pieces of data as data collection points for outcomes in your trial. And thinking about working pragmatically, it's nice to work with data that's already been collected by somebody else, so that you can not spend your time or your money prospectively collecting data, especially if you're thinking about doing something for a really large group of individuals. So how do I get my hands on the health data is probably the most common question that we receive. And this is from the Center for Health Informatics website. So if you can't read the full graphic here, you can find it online. And we've got a great roadmap that can walk you through the steps of how you would access this healthcare data. And probably somebody did this in order for a reason, but you would start with Stacy's talk about ethics. So we're going to go through a research ethics process to understand your study. Once you come through REB approval, you will go through a health system access request. So again, working with our partners at Alberta Health Services to work on that data release. This is things that we can help you with at the Center for Health Informatics. We have lots of really great staff and analysts that are very, very skilled in these processes. So we can help you navigate that piece. And then once you have gone through your approvals to run your study, access data, then you're going to have to start thinking about what are all the different types of data points that I need and where are those found. And again, we have lots of highly trained people that can help you understand the data points you want, what databases might they be in, how could they be linked to data you might already have. And then there's also great analytics support in the health policy trials unit. We have great analytics support as well. So if you have an idea, you need some data access help, but also maybe you need some data analysis help, we've got lots of people that would love to come join on your project from that front as well. Now, that's maybe not the most exciting thing to think about, is how do I access data? So I also wanted to talk a little bit about the outcomes you might be gathering in your pragmatic trial and how to think about outcome assessment pragmatically, so that again, you're not spending time and effort up front on a prospective collection of outcomes. And I'm going to use two examples from some of my experiences working with the Calgary Stroke Program on some pragmatic trials to understand outcomes that we were able to collect, and even some other variables we were able to collect out of routinely collected administrative health data, but it requires a little bit of creativity. So remember, the purpose of all of these pre-collected data points is not for research, but is for routine healthcare use, and often it's for billing. So we have to think about that this data might not match your purpose, but how can we get creative? So here's a creative example, and you do not need to read anything that's on the slide. All I want you to know is that stroke outcomes are really complicated. So we are working to design a pragmatic trial in the stroke space, and often when you talk about assessing the outcome of an individual who's had a stroke, we're talking about assessing maybe the level of disability that person might be living with months to years after their stroke. That is something that is really, really hard to assess en masse and something that is impossible to assess using just administrative health data. We often look at the modified Rankin scale score, which I have on the screen for you, and it actually takes a trained assessor to go through several questions with a patient to understand the level of disability they might have. You can imagine that is never going to be something that's routinely documented in your healthcare record. So in designing a pragmatic trial where stroke patients would have been enrolled, we had to think, how else can we assess outcomes in this population pragmatically? So we did some thinking, we did some working with patients, and we found a pragmatic and also patient-centered alternative to this, which is called 90-day home time. And 90-day home time is the number of days in the first 90 after your stroke that a patient spends at home. This is something that is super easy to find in administrative health data because we have great data understanding, if a patient was in an emergency department, an acute care unit, in a long-term care facility, if the patient had passed away, and if the patient has done none of those things and is still in Alberta, they must have been at home. So this is something that you can gather out of routinely collected administrative data. Also, it happens to be a really nice patient-centered outcome because this is what matters to patients. They consistently tell us, we want to go home. So if we can measure the amount of time the patient's spending at home, that's a great outcome as well. And nicely, it is correlated with other disability metrics. So we weren't losing the outcome we actually wanted to assess, but we could assess it super pragmatically in a different way. And then I also wanted to give one more example about covariate collection. We often talk about needing to risk adjust patients to understand, if this is a patient that had a really severe stroke versus a minor stroke, comparing those outcomes head to head might not be fair. So we need to go through a risk adjustment process. Often we measure how severe a stroke is using something called the National Institute for Health Stroke Scale, or NIHSS. This is what the NIHSS form looks like. It is almost impossible to go through even if you are medically trained to do so, and is something that is never going to be in an administrative health record. But it was really important to be able to risk adjust our patients. So we spent a long time with a group of very impressive data scientists to understand what pieces of data are actually in our administrative health record that are highly correlated with the NIH stroke scale, and could we come up with our own risk adjustment tool that is easily collected from routine administrative data elements. And a group of Toronto worked on this for quite some time and were able to do it. So we now have something called the passive stroke score. It comes out of routine administrative data using data points like, did the patient have to be intubated? Did they arrive by ambulance? Things that are routinely collected. And so we can use this to risk adjust in a pragmatic trial. So to wrap up, to say you might have to think creatively about some of both your outcomes and your covariates as you think about how to run your trial more pragmatically. And if you need some help doing that or some help understanding how to access administrative data, we would love to chat with you at the Center for Health Informatics.
Great. We do have a couple minutes for questions. I'll ask Terry and Tegan and Stacy and Becky to come up, and we'll take a couple of questions. Oh, yeah, please go ahead. Yeah, thank you.
Always me. So I've been in the interesting position of doing a research study, but as an employee of emergency medical services. But we wanted to do a thing, and I said, let's do it as research, and they said, okay. So it was interesting, and there's a lot of challenges I didn't anticipate. But is it possible that there's just advice or guidelines out there already for when you're doing that? You're doing it as an employee, but also as the researcher. So I kind of had a dual role there. Any thoughts there? Because I'd like it to be easier next time.
Your question more for ethics or for who are you thinking? Any of the panel? Okay. Any thoughts? Yeah, go ahead, Becky, please.
I can go first. So I think the key, when we see this a lot, where employees are undertaking research, and there is a lot of times, the question of what hat are you wearing when you're doing the research? Because if you're submitting as a UFC affiliate, you're submitting to CHREB for ethics approval, then that means you're leveraging your University of Calgary hats. And as University of Calgary, the way the Health Information Act is worded, it is a disclosure of information. But then if conducting research as an employee, Alberta Health Services and the future health system will have a designated board of record, which is not CHREB. And currently, employees of AHS submit to the HREB, Health Research, U of A, the U of A board, yeah. And then there's a formalized agreement to enable AHS employees. And so when that happens, then to us, that's using the employee hats, and then different considerations for operational approval, for health information disclosure. It could be a use of information instead of health disclosure of health information. So that's kind of the legal justification. It's really being clear about what hats you're wearing, and one of the indicators is the board that you're applying to. It's an indicator. It doesn't mean that's the case. So, and then, agreements, the implication for agreements as well too. So it's the kind of that legal structure behind it. So to make it easier, I would say be very clear about what hat you're wearing, and then make sure that, if you're doing it as an employee, make sure your management team is on board so they can give you the approval to say that the system is paying for that time to do this work.
Got one more. I've got a question here. Very good.
Thank you. So I have a kind of a general question. I'm not sure. I think it might be targeted to a couple different people. So my name is David, and I work at Hull Services, which is a large youth mental health provider here in Calgary. And one thing that we're interested in is trying to understand, the impact of our services on clients. But one issue that we run into is, we know the services that we provided to our clients, and we may have good outcome data until the time they leave our care, but we really don't know what happens to them when they've left our care. And so it was occurring to me when I was, hearing about the data collection through AHS, I was kind of wondering, is it a thing that's happened? Are people doing this? Can we do this? Where, I guess you would apply and you would try to get long-term health records on past clients of your agency to try to understand the long-term impact of your services. So I guess, is that a thing people are doing? Can we do that for a specific subset?
Maybe I'll throw this to two people. Maybe Jessalyn can talk about kind of linkage of, you mentioned data you already hold and linking that to health systems data. And then maybe Stacy could talk about what ethical permissions would be required to do that.
Perfect. So I was just going to say, I'm not going to speak to the ethical component of that at all. But from a technical standpoint, technically that is something that is possible, but a few things need to come together. So we need to have really good agreements between yourself as an organization and also the health system and anybody else that might be involved in the process to understand the data sharing agreements, the reason for linkage, and also who is going to then hold that linked data, because often as we look through data linkage, data becomes more identifiable the more information you have on a person. So there's some legal components that you're going to work through to understand, how do we link appropriately, how do we maintain patient privacy, and who's going to hold that linked data, and also who is going to do the linkage. But technically it is feasible, but you'll run into some creative roadblocks along the way.
Talk about what's required for linking primary collected data with routinely collected data.
It's not so much the linkage. From an ethics perspective, it goes to affiliation and who has oversight over the study. So if you're not affiliated with one, like the University of Calgary, for example, but you're pulling on AHS data, you need to sort of backtrack and navigate which board you need to apply to. so that they have an ethics approval in place so that they can then release the data. So in Alberta, there are boards at the U of C and U of A who have designation authority to review studies that seek to access personal health information for research purposes, as well as the provincial board, which is the Health Research Ethics Board of Alberta, that has 3 committees who serve researchers who do not have those 2 institutional affiliations, but do have the designation status to review that kind of work.
Thank you, Stacey. I'll just ask one question before we wrap up. If somebody had a project that they knew was not going to be super straightforward in terms of the usual pipeline of ethics approval through IRIS, then operational approval, if there was going to be some additional considerations, either waivers of consent or things that we run into with pragmatic designs, do you recommend that they contact you to discuss these things before they just submit it through IRIS? Like, what would you recommend if somebody's planning a complex pragmatic trial? Should they come to Becky or Stacey or both of you and say, what do you recommend, or how do we go through this? Or should they just put it in IRIS and let what happens, happens?
Well, I'll boldly leap on and say, what are they putting in IRIS if they're not sure what they're doing?
I'm saying if they're looking for like the waiver of consent thing, for example. You mentioned they have to justify, so should they just put all that in IRIS, or does it merit a pre-conversation?
It depends on their confidence up front.
Okay.
So if they know the rules and they've applied them and they have a solid strategy, we welcome them to put it in and we'll look at it. If there's any ambiguity or there's wanting problem solving and collaboration, of course, by all means, our frontline analysts are great. I'm relatively great. We're all happy to talk and work through these things up front to get you going. And I think the same with Becky's team.
Becky, for you, would you be happy to receive like a Connect Care build just kind of through IRIS and be like, oh, what's this? Or do you want to have a discussion with the investigator first?
It depends. If the investigator is very familiar with the system and our processes, and they've done it before, and some of the builds are very straightforward, very simple, especially if they don't fire at the front line, like the alerts that I talked about. Very straightforward, and they've done it before. Submit it. We can typically do it. But if they don't have confidence that it is going to be supported, or it is technically feasible, or that operations will support, then it is worth a discussion with, I think, anybody here sitting around the table can navigate to the right group, and the support that, Terry and Tegan talked about too. There's services that are available, so just talk to somebody. And we, for us on our team, we've got regular conversations with Stacey, with HREB, with Hariba, like we are in constant communications. And so just find someone to talk to if there is any doubt. But if you're wholly confident, then submit it. Not through IRIS is one consideration, but the build request form is ask or submit it, and then we'll give you that determination.
Thank you to the panel, and please join me in thanking them for their time. I'll turn it back over to Paul and Tessa to wrap up for the day.
Thank you all so much for being here today. We hope that this gathering has helped build bridges between academic researchers and community partners, and maybe even spark some more interest among the folks here in working more closely together on policy trials. Throughout the day, we've heard about successful collaborations where research and lived experience came together to inform policy and drive change. These aren't just inspiring stories, or stories with a point, as Dr. Huang would say. They're proof that collaborative policy trials are both possible, but also very impactful.
So a couple of additional thanks before we wrap up. So first, I want to thank Mariko, Demaladi, Leslie, Angie, Brittany, so our comms team and event team that does so much work in the background to make these events a success. So a round of applause for them, please. Anything else? And also to all of you, thanks to everyone in the audience. Thanks so much for coming today, for your time, for your insights, your commitment to evidence-informed, community-driven work. We're really looking forward to seeing where these conversations go that you've had today. And finally, if you're interested in continuing today's conversations and collaborating on health equity solutions, I want to invite you to join us at our next O'Brien event, which is going to be hosted by the Health Equity Hub. It's on June 13th, Friday the 13th. Hopefully you're not superstitious, but it's at the YWCA, and it's called the Health Equity Connector Forum. It's going to be a half-day event designed to spark new connections, explore transdisciplinary partnerships, and discuss early-stage research ideas on health equity. You've got that at your table here. It's the colorful piece of paper here, so please look at that. I've heard that register as soon as you can. There's fairly limited space on that, so we'd love to see you at that event as well. Quick note, for those of you that have signed up for the bonus workshop today, please stay in your seats. So Dr. Amity Quinn is going to be facilitating that session, and she's going to provide some initial remarks in just a few minutes. Essentially, it's going to have two parts to it. It's going to start with a discussion around developing an effective research collaboration and how this could lead to planning a trial. And then the team within the Health Policy Trials Unit is going to share their experience developing a trial with the YW Transitional Housing Program. For those that didn't sign up and you'd like to stay, please, we'd love to have you stay. If you have to go, we thank you again for your time today. One last thing that I just found out from Angie is we also have the post-event survey. There's a bunch of papers in the middle of your desk here, but please fill these out. Anything that you enjoyed, anything that we can improve on these events is always appreciated. So if you could fill that out and leave it just in the middle of the table, we'd appreciate that. On that note, though, we really appreciate your time today. I hope you had a wonderful time. Thank you again for coming, and we'll start up the workshop in about 5 minutes. So thanks again, everyone.